Good morning. Hello. Good morning. Very good morning. Paul. I welcome all of you on behalf of Solapur Academy of Pediatrics for another module, Diagnostic Stewardship. I welcome all the speakers, respected Dr. Pramod Kulkarni sir, Dr. Keyur Mahajan, Dr. Suchita madam, Dr. Aishwarya madam. Uh, some technical delay is there. We will start with the module. So for today's diagnostic stewardship module, we have our own speaker, Dr. Pramod Kulkarni sir. He has completed his MD MRCPCH and he is working as a consultant pediatric infectious disease at Smile Clinic, KM Hospital, Dinanath Mangeshkar Hospital, SK Navle Medical College and Unique Hospital, Pune. We know him as he is a regular visitor for our module. Whenever we request him, he is enthusiastically ready for Solapur. I thank you very much, sir, for your presence. Yes, yes, sir. Vidyanand. Next. Next. Next.
I introduce Dr. Keyur Mahajan sir, our next speaker. He is pediatric infectious disease consultant, presently working at Dinanath Mangeshkar Hospital and Mai Mangeshkar Hospital, ORJ. He is diploma in infectious diseases.
And the third speaker for today is our own Dr. Aishwarya Kulkarni. She is an infectious disease specialist and currently working in Ashwini Hospital and Venkatesh Hospital in Navi Pet, and we welcome her. Our next speaker is Dr. Suchita Pofle ma'am. She is a pediatrician and adolescent pediatrician at Umarga, speaker at pediatric and social platforms. Welcome ma'am.
I request Dr. Pramod sir to come up and introduce the diagnostic stewardship module.
So, good morning everybody. Nice to be back here at Solapur, and thank you Solapur IIP for inviting all of us. Diagnostic stewardship, what it is? गेले 20 वर्ष आपण अँटीबायोटिक स्टीवर्डशिप ऐकतो आहोत. मग डायग्नोस्टिक स्टीवर्डशिप काय आहे? स्टीवर्डशिप म्हणजे काय? स्टीवर्ड म्हणजे काय? आपण जहाजाचे स्टीवर्ड असतात ऐकलेलं असतं. ओके, तर स्टीवर्ड म्हणजे एखादी गोष्ट जपून वापरणं विथ बेस्ट ऑफ इट्स ऑप्टिमम और बेस्ट ऑफ इट्स यूज, याला स्टीवर्डशिप म्हणतात. जपून वापरणं, चांगलं वापरणं, याला स्टीवर्डशिप म्हणतात. अँटीबायोटिकचे आपण आता बघितलं. आता अँटीबायोटिकच्या पलीकडे जाऊन डायग्नोस्टिक स्टीवर्डशिप म्हणजे काय? आपण ज्या रोजच्या ज्या सगळ्या इन्व्हेस्टिगेशन्स करतो आहोत ते कसं योग्य प्रकारे वापरायचं, कमीत कमी रिसोर्सेस, सगळ्यात चांगल्या टेस्ट आणि त्याचा आपल्याला क्लिनिकल डिसिजन मेकिंगला कसा उपयोग होईल, याचा वापर कसा करायचा याच्याविषयी. यापूर्वी हा विषय IIPच्या मॉड्यूलमध्ये कित्येक आलेला होता. 2 वर्षापूर्वी अल्ट्रा म्हणून मॉड्यूल होतं, आपल्याकडेही झालं होतं, तेव्हा होतं. त्याच्या आधीपासून पूर्वीपासून हा विषय आहे. कोणतं इन्व्हेस्टिगेशन कधी करायचं, कसं करायचं, इंटरप्रिट कसं करायचं आणि डिसिजन मेकिंगला कसं वापरायचं. तर आता हे तेच आहे. We have the same, but it is more crystallized, and over last 10 years there is a structured development and refinement of this concept of diagnostic stewardship. So we are looking at this module. This module has been prepared by the stalwarts of pediatric ID in India, Dr. Vijay Yevle, Dr. Suhas Prabhu, Dr. Dhanya Dharmapalan. They were the main people behind preparing this module. Dr. Sanjay Ghorpade, our own alumnus, is national convener, and the contributions have been made by many of the national IIP seniors in the field. So this is really a good module. Actually preparing a module takes a lot of time. There is lot of brainstorming. At least 8 to 10 different meetings do occur with detailed discussions, what is to be put in there for proper messages, carry home messages, what is relevant, which is not relevant, what is along in the line with the national guidelines and national protocols or international consensus. All these things are thought and then it is presented in the module. So as Dr. Basavaraja, our Central IP President says, old wine in new bottle, but it does matter. There is something new in the package as well and the bottle as well. Because you know how it is presented matters a lot for us to take a message home. So this diagnostic stewardship is just in simple words, which test to be done, when to be done, how to be done in the best possible way to get the best outcome, clinical outcome, to make best decision making and best clinical outcome. Beyond that, there is one more target of it, which is hidden, is a primary gain, to be very frank. Antibiotic stewardship बरोबर diagnostic stewardship केली. Antibiotic stewardship मध्ये diagnostic stewardship येतच येतं, essential component आहे. तर diagnostic stewardship ultimately leads to antimicrobial resistance reduction. That is antibiotic stewardship. It is essential component of that. हे दोन्ही तिन्ही गोष्टी एकत्र अशा जात आहेत. So this is the purpose of this module and we are going to learn with the common OP and IP scenarios where we can practice this diagnostic stewardship. In common OP scenarios, febrile illness, short duration febrile illness, PUO, lymphadenopathy, then PICU, neuroinfections, GI infections, respiratory infections. These are the common OP and IP scenarios. A primary or secondary level care pediatrician deals with various tests. When to do, how to do, where to do, how to interpret and how to use it best for your patients and your own best practice. So these are the things which we are going to cover. Of very interesting, let me tell you, there is nothing which is boring here. And it is case-based, interactive. You will be asked to participate. You have to be attentive, attend every case given. And there is a different question and the options are going to resolve all our myths and doubts about which test, when, how, why. All these things are being addressed here. So that is about diagnostic stewardship. And the common tests are being dealt with. There is one section on dealing with PICU, as many of us are dealing with critical care as well in all the cities as well as in Solapur. So there is a section of ICU. And as another component of diagnostic stewardship, there is a role of the third pillar of infection control practices is naturally vaccination, and our sponsors there is a section on vaccines, the relevant one, common one, a short one which will be visiting that also. So again the same questions are being asked and answered. Age-old practices like Vidal, NS1 when to be done, CBC का क्या रोल है, CRP प्रोकैल करना है या नहीं है, कल्चर करना है या नहीं है, मॉलिक्युलर्स आ गए उसमें क्या है, कौन सा पैनल करना है काही नाही. हे सगळे प्रश्न तेच आहेत पण त्याची उत्तरं जास्ती क्रिस्टलाइज्ड विथ जस्टिफिकेशन आणि रॅशनलायझेशन याच्यामध्ये दिलेली आहेत.
फाइनल ये पासवर्ड है कैंसिल करो
So without wasting much time, there is a big time constraint. We have started late, we have to finish up early. So we'll be little running through the slides where relevant and where interactive part is there, we'll be touching it in detail. So these are the central IIP people behind this module. Then these are the contributors. As I said, mainly prepared by Dr. Prabhu, Dhanya and Vijay sir. So diagnostic stewardship, let us start with the case straight away, how it applies. So this is a 6-year girl having fever for 5 days, liver is just palpable. Which investigations will you do? This is the option given and these are the routinely available investigation we will think. So 5 days fever, short duration fever, 6-year-old girl with just mild hepatomegaly, CBC, CRP, PBS, rapid malaria antigen, dengue, NS1 serology, Vidal, urine routine blood culture, X-ray test. All are at our disposal. What we will do? How to decide this? This is a common scenario, nothing difficult for us to decide about it. So what will you choose? Tell me one by one. CBC, will you do? Yes. CRP, will you do? Yes. PBS for malaria, rapid malaria antigen? Of course, where relevant, it depends on epidemiology. In Pune, we don't have much of malaria over last few years. Probably same is the story in Solapur also. May not be relevant for our area, but there are areas where malaria is there it applies. Yes, dengue, very much there. Vidal, a big question. Do you agree with Vidal? You don't agree, but you do it. Okay? Urine routine. Yes, definitely. Blood culture. May or may not, highly desirable, we agree, but we don't send mostly. 5 days fever, why not blood culture? Okay, then X-ray chest. Is it, there are no respiratory complaints, why X-ray chest? So these are the simple questions and you will see. This child comes with HB12, total count 3,200, poly is platelets 1.3 lakh, CRP is 18, PBS negative, dengue negative, Vidal 1 in 160 O at H, urine routine 6 to 8 per cells, blood culture is sent, X-ray chest normal. And routine scenario, these are the reports. How to go ahead with these reports in this child? How will you go ahead? What is your interpretation? You have a case, you have got reports, which you have prescribed. Where are we? What is this? How to treat this? The questions remain haunting us more than the initial setup. Typhoid, UTI, dengue, smear negative malaria, all answers to be, have to be there. So further characterization of the symptoms will help us. Fever was there for 3 days. Now the child is febrile for 36 hours. What does it mean? Day 5 of fever doesn't mean the fever is running. So we have to ask what has happened to the fever. Fever again since 24 hours. So this becomes a typical biphasic fever. 2 दिवस आलाय, 1 दिवस, 1.5 दिवस नाही आणि पुन्हा आलेला आहे. Biphasic fever equal to viral. Very simple to clinically diagnose it. Fever again since 24 hours. Had severe myalgia for 2 days. Very good clue for again a viral infection. It's a systemic viral infection. 2 days in between, so that has also resolved. So the clinical characterization of the symptoms again helps us here. So how are we going ahead? What went wrong in this test? So what is the right test? What is the right time? What is the right patient to select? So we have done all these tests on day 5 of fever with no results in our hand to guide us about further action to be taken in this child. So CBC justified, CRP yes justified, malaria depends on epidemiology. Rapid malaria antigen again not justified. Dengue very much justified. Vidal not justified. Urine routine not justified. Why not justified? 6-year-old girl, 5 days of fever with no urinary symptoms. Can it be UTI? that is asymptomatic UTI. It is common in young children below 2 years, especially infants, not at this age. So that becomes irrational. Blood culture, day 5, when the clinical presentation tells you this is biphasic fever, typhoid, you know, it's going to be rising fever continuously. There were 36 hours of no fever here, so Vidal is not justified in this case. With that myalgia there, we are again with a viral fever. Okay, X-ray chest, no role again. So this is how we decide about the routine test which we do routinely. Unselected use of lab test without considering the pre-test probability, which is a key word. Let me tell you, any diagnostic test, it will be most useful if you decide about the pre-test probability. It is the major determinant of success or utility of the test you are carrying out, is the most important one. So pre-test probability of infection is mostly decided by epidemiology and the clinical characterization. Here we saw the biphasic fever and myalgia told us this is less likely to be typhoid, more likely to be viral infection. Again, this is how it increases our pre-test probability. Can rapidly lead to false positive tests. We had pus cells in that urine. We had that Vidal positive, all false positive. Again, misguiding us about the next action to be taken. So creates a diagnostic uncertainties as well as causes harm. Definitely harm is there. Patients are spending money. Patients are taking discomfort. Patients are taking pricks and bloodletting as well. All this is a harm definitely. And not only that, with the Vidal scene, pus cell scene, if somebody tends to prescribe antibiotic, that is actual harm we are doing to the patient when it is not indicated. So this is what is called as diagnostic stewardship, and this is the need of diagnostic stewardship. So diagnostic tools judiciously usage after consideration of clinical symptoms and signs. RRR. Right test, right time, right patient. These are the three basic. Our contributors have made it a simple algorithm or way to go ahead, a structured way, questions to be asked. Is it a right patient? Is it a right time? Is it a right test? Very simple. These are the three things. Not only that, what do you mean by that? Right test is right specimen, right storage, आणि राईट ट्रान्सपोर्ट या महत्त्वाच्या गोष्टी आहेत. राईट टेस्ट म्हटल्यावरती तिच्या खाली या 3 गोष्टी आल्याच पाहिजेत इसेन्शियली. विदाउट दॅट इट कॅनॉट बी ओनली सिलेक्शन ऑफ राईट टेस्ट. इट इज हाऊ टू डू इट. ओके, then you have right time, right patient. Not only that, when you get the report, interpretation has to be right. I think this is the most crucial thing. You may err a little here and there with pressures or practice, but interpretation is the right thing which is going to determine the harm and the usefulness of the test which you have done. And ultimately it has to lead to safe, effective and efficient patient management. So this is what is called as diagnostic stewardship. The red rectangle here tells don't mix it up with the cost factor, because the costly investigation also can be appropriate in particular scenarios. Not in every scenario. We know molecular testing. We have BioFire, PCR. You send the sample, within 2 hours you get a report of HSV1 positive or HSV1 negative. You can start a cyclovir or you can stop a cyclovir. That is the utility of it. It definitely is indicated, rational and justified, but not in all cases. So not in every pneumonia case, every fever case, we are going to use the moleculars one. So though these tests are expensive, costing about 12 to 14,000, they definitely have their place, validity and utility, which is fully justified, scientific and has to be done. So don't mix it up. Stewardship is not related to cost. When you are doing CBC CRP n number of times, again you have to think of the cost. Nowadays CBC CRP comes at 700 to 800 rupees. Doing it repeatedly just to monitor a child of pneumonia or a fever is of no use, is of absolutely no use. So there we have to think of cost of the test. So these are the various angles of it. So optimize outcome, improve antimicrobial usage, that is the decision we are taking, ultimately contributing to curtailing the antimicrobial resistance, which is a big problem. So stewardship to combat antimicrobial resistance is our final aim. Local, regional, state, national, global. Everywhere, everybody is struggling hard to cut down the antimicrobial resistance which has reached our thresholds, our hospitals. So, antimicrobial stewardship, diagnostic stewardship, infection prevention and control practices stewardship, and in every patient with possible infection. So, this is the main aim of this module. Where is it? Yes, important setting, OPD, IPD, routine infections which are non-severe, that routinely do not need any test, as well as, and these patients usually in OP are immunocompetent, where the bugs are going to be routine community acquired, less likely to be resistant, the samples are likely to be contaminated, colonization is more likely to occur, and the tests done in these patients are likely to be false positive and misleading us for inappropriate antimicrobial prescription. And sometimes in ICU and immunocompromised patients as well, where investigations are a must, and we depend heavily, we little overdo it, but it is very often when we are doing it too much, or investigation, they have to be rationally done and rationally used. There is tendency for excessive use of microbiologic testing in ICUs as well as immunocompromised patients. So it has to be a good balance between unnecessary tests and wastage of resources and harm, as well as proper use has to be done to pick up the diagnosis in time, because we know in ICU immunocompromised, every minute and hour counts for life of a patient. Even 1 hour delay of antimicrobial administration, appropriate antimicrobial administration, is a determinant of increased mortality by 50 to 70%. So there it becomes important. So timely, earliest, appropriate, correct diagnosis, and avoiding the misuse, overuse, false positive use of tests. So here we have, for that, we have to plan about the investigation and act according to that. Let us go to the second case. 4-year boy from Mumbai, July 23, fever without focus 3 days, is febrile, liver just palpable. Again the questions come to you. Which of the following tests will you order? So again, all these cases, you know, that is what we do in OP. Simple clues are there, based on which you take your clinical decisions, make your clinical impression about the probable diagnosis, the syndromic diagnosis, possible etiology, as well as severity of the illness, and act according to that. So this is the case. 4-year boy, Mumbai, July, fever without focus 3 days, he is febrile and liver is just palpable. Now choice is yours. Tell me, CBC, PS for malaria, CRP, dengue, urine, blood culture, what will you do? So CPC, yes. PS for malaria, yes, Mumbai they have malaria. CRP, yes, why CRP? We do it as a routine. Definitely it's useful for it has got a very high negative predictive value of serious bacterial infection. Isolated test, CRP will deal with that, is of no use, should not be respected. It's a part of sepsis screen package you have to look at with all the other changes in the other tests, not isolated. But definitely we do it routinely, and now it is a little cheaper also. Dengue NS1, yes, monsoon season. Dengue IgM, IgG, are you going to do it? Day 3 of fever, it's of no use, unless it's a secondary dengue, which is a less likelihood. Urine routine. Again, 4-year-old boy having fever for 3 days without urinary symptoms, less likely to have UTI. Blood culture, are we going to do blood culture? Day 3, it can be a viral infection self-resolving within 3 to 5 days. Why to do blood culture if the child is stable at this stage? But we will do it. Why? Why we will do it? Absolutely common DD is enteric, and there is no other gold standard of enteric diagnosis, and earlier you do in the course of illness, more likely you will get it positive, and more likely the defervescence time and everything is going to be cut down. A culture proven enteric is unchallengeable, I tell you. If you have a positive culture, it is definite Salmonella. If it is negative, you can vouch on, we have done culture in right time, less likely to be typhoid. Okay? So here HB is 11, total count 3200, PS for MP negative, CRP is 7, NS1 positive, blood culture sterile after 2 days. What is your diagnosis? Definitely it's dengue. So here what you have to consider? Pre-test probability, that is clinical impression, sensitivity of test, specificity of test, and performance characteristic. This is the additional characteristic or the consideration of the test which you have to keep in mind. So what we have seen, sensitivity, specificity, we have learnt over decades now. What additional thing? Pre-test probability and performance characteristic are the two things of any test, any investigation you are choosing. You have to keep in mind. So dengue NS1 and IgG IgM in this child comes negative. How do you interpret it? It is day 5 of fever. Is it not dengue? Exactly, that's the window period. So NS1 positivity is highest in first 3 days. Can be positive up to 10 days, but reliably first 3 days. This is day 5. IgM comes after 5. So this is the window period during which both can be negative, still it can be dengue. Then what helps us? Our clinical acumen. If the child is behaving like dengue, if goes into the critical phase in next 2 days after becoming a febrile, you have to keep, you cannot rule out dengue with this test report here. Okay, so right test, right patient, and right time. So here, how will we analyze? Was the were these tests right? Yes. Was it a right patient to choose? Yes. Right time? No. Because NS1 IgG IgM either done before 3 days or after 5 days are going to be useful. During this window period, performing this test is not going to help us anyway. Yeah, secondary dengue, I do agree, but here they are considering primary dengue. Yes, that is a finer, but let me tell you, these days card test, especially NS1, is highly reliable. It is akin to ELISA, let me tell you. They are very reliable. It is the serology which is a problem where ELISA matters a lot. And again to tell you, NS1 is a direct microbiological test, highly reliable antigen of an organism, while serology per se stands very low in any diagnosis. So serology by ELISA or by best of the method stands below the direct test. Basically, the problem is the, I agree with you. I agree with you. There are two different things. The things in WHO and national programs, the priorities are different. In private practice, priorities are different. What is important for us, individual patient, if he is having dengue or not, so that we can give anticipatory guidance and be prepared for the critical phase when the problems can occur. When the problems can occur. In government, they don't have problem about diagnosis of dengue. Dengue hospitalization is 1 in 100. Warning sign is 1 in 100, hospitalization 1 in 1,000, critical patient 1 in 10,000. You see hundreds of dengue. How many of them become critical, land into PICUs? 1 in 1,000. In government setup, in public program, they don't want diagnosis of dengue. They want the mortality and morbidity to be managed in time. So critical phase is their target. So diagnosing dengue and getting overload of dengue positive patient in your community setup is not desirable at all. Not desire. So the priorities in public health are different and private are totally different. Here we are worried. We are telling the patient on day 1 or 2, your child has a dengue, let us be watchful. What actually we do, we admit that child. We don't ask them to watch for warning signs and get admitted SOS. We admit them on that day, keep them for 7 days till the critical phase is over, and then declare your dengue was bad and we have treated it. This is what happens. This is what happens. Actually, we should go by the protocol by WHO. Second is warning signs, counseling, hydration, paracetamol. Next to it, warning signs are there. Hospitalize, high risk, hospitalize, monitor. If goes critical, very rarely, 1 in 1,000 patient goes in PICU of dengue. So mind it well, in private practice also, it is the same scenario, it's not different. Please just label it as dengue, and NS1 is highly reliable. Let the agencies agree with or not. If what we are dealing with is the science related to microbiology and infection, not the policies and strategies depending on the setup we are managing. NS1 positivity, sensitivity very high, specificity very high. It's a direct test. It's a direct test. No question about it. Let it be card test. Peri PCR kahan milta hai? How many of you have done PCR dengue here in Solapur when it is available? Just tell me. We don't do it at Pune. We don't do it. When a cheaper test is available, which is equally useful, why to go for a higher level of test, which is expensive and not easily doable? It takes one day for PCR to come positive. The sample, it is minimum 2,000 rupees you are going to spend on that. NS1 card test, a lab technician, let us not blame them, can perform in the periphery of Solapur district, and a positive is a very much screening test for a possible dengue, who can land into problems. It's very useful for the family and the primary care pediatrician as well. So don't go by that. So let agencies agree or not, microbiology and infection and science are there. The policies are different. Okay? So NS1 done by any method is very good test. Ideal is ELISA. Serology is an inferior test, even done by best of the possible enzyme immunoassay and ELISA. Again, the interpretation is very, very tricky. So, right test, right patient, right time. Was it a right test? Yes. Was it a right patient? No. Why? We have seen about the timing. Right time, it was not a right time also. So, low pretest probability. Why this was not a right patient? Day 3 we have seen. So, when the tests are going to be negative, you know this is a window period. It's of no use. Okay? So, clinical impression based on history and physical examination, we decide the pre-test probability. Performance characteristic, both will determine the right test, right time, right patient are there. So, right test, pre-test probability and performance characteristic of that particular test. 9-year-old girl, high fever 3 days, cough, breathlessness, right-sided bronchial breathing, CBC, CRP, throat swab, PCR sent. And this is the X-ray. What is your opinion about this test? And again, put it to the same filter of right test, right patient, right time. What is your opinion? CBC, CRP, throat swab, PCR. Before that, we have seen pre-test probability and syndromic diagnosis. What is this? 9-year girl, 3 days fever, cough, breathlessness, bronchial breathing. What is this? Community acquired pneumonia. Simply you got the syndrome. Which are the tests to be done in this scenario? CBC, CRP, throat swab, PCR is done. What is your opinion about CBC, CRP? The question is, what is the role of CBC, CRP in diagnosis and management of community acquired pneumonia? 0. No diagnostic test for pneumonia is a clinical diagnosis. Okay? WHO, all agencies, even our IIP and all the bodies, international bodies, we do CBC, CRP, X-ray, that's a different story. But even X-ray is not indicated in community acquired pneumonia unless it is severe pneumonia, complicated pneumonia. It is not routinely needed. Okay? Then throat swab PCR, it is highlighted here. What is your opinion about throat swab PCR? The X-ray is showing typical right middle lobe pneumonia. What is your opinion about it? Throat swab PCR. The question is very elaborate question. Whether it is right test, right time, right patient. All 3 questions have to be answered here. And the PCR is done. Probably this is a patient from Pune. And we get rhinovirus isolated by the BioFire upper respiratory panel. Okay, the counts are HB is 9, total WBC 9,000, CRP is 200. Where are you with this basic test done and advanced test also done? Is it rhinovirus pneumonia? Is it not pneumonia? Counts are normal. CRP is 200, complicated pneumonia, empire mein kya? So every test has got its own value in diagnosis. You have to interpret it. So is this a viral pneumonia? Why this is not likely to be pneumonia? You again come back to your clinical acumen again here. Radiology helps here. It's a big lobar pneumonia, which is less likely to be viral. We know very well. It is not 100% predictive. Radiologically, you cannot diagnose pneumonia, differentiate pneumonia etiologically. But still, there are some clues. So, a lobar pneumonia in this old child is likely, with bronchial breathing, is likely to be a lobar pneumonia, which is likely to be more likely to be bacterial. More likely to be bacterial. Okay? Will you give antibiotic in this case? Yes. Then how will have these tests help you? Which test has helped you giving antibiotic? None of these tests have helped you, otherwise also you are going to treat. So whether all these tests are justified, that is what WHO says. No role of any investigation in pneumonia. OP, not IPD. IPD we have to do, we do also. Okay, so was it right test, right patient, right time about all the investigations? Right patient, yes, clinical syndrome pneumonia. Right test, no, wrong test. Right specimen, कुठला स्पेसिमन चुकला आपण राईट टेस्टमध्ये राईट स्पेसिमन बघितला राईट साईट स्टोरेज ट्रान्सपोर्ट बघितलं इथं कुठला स्पेसिमन पाठवलाय आपण कुठल्या क्लिनिकल सिंड्रोम करता न्यूमोनिया करता आणि काय पाठवलंय थ्रोट स्वाब इट्स अ रॉंग स्पेसिमन बिकॉज you have to get a specimen from the site of disease and it has to be truly representative of the infection underlying. You have got a pneumonia which is lower down in the respiratory tract and you are sending throat swab. The correlation is pre-test probability is per se 0. So doing it, so this is a wrong specimen which is chosen. Okay? Right patient, specimen not representative of site of infection. Okay, one more case. 12-month girl, high fever 2 days, tachycardia, mottling, CBC, CRP, urine routine, urine culture done. What is your opinion? Right patient, right time, right test. Answer those 4 tests given. You have got a clinical background. Think about pre-test probability, clinical syndrome, and think about the investigations. 12-month girl, young infant, high fever 2 days, more likely to be infection, more likely to be bacterial. Tachycardia, definitely some hemodynamic disturbance, provided the child is febrile. Mottling, a really sinister sign, probably has got perfusion issues. And in this child is mostly a septic child, bacteremic child. A young infant, without focus, you don't have anything else. So fever without focus in a young infant, which is likely to be bacterial, this becomes our fever of short duration, this becomes our clinical syndromic diagnosis. CPC, CRP, urine routine, urine culture. What is your opinion? Are these right tests? Is this right time? Patient is right, we have already seen. Yes, these are acceptable. So HB is 9, WBC count 29,000, CRP raise 130, urine packed filled pus cells, urine culture, mixed growth E. coli and Klebsiella. Everything was going very nice until the last report. Urine culture rightly sent, correctly sent, nothing wrong about that. And the result is mixed growth of E. coli and Klebsiella. What is your interpretation? Is this UTI or not UTI? Is this E. coli or Klebsiella? Which antibiotic to be used? Parenteral, oral? What is the current susceptibility of E. coli, Klebsiella? Which antibiotic is to be given to this child? Is this not UTI? So diagnostic criteria of UTI, clinical background, pyuria, bacteriuria, simple. Pyuria, bacteria. You have got pyuria, clinical background. Yes, a small kid can have UTI. Fever without focus in infant is predisposing clinical situation for UTI. Okay. So pyuria is definitely there. The problem is the culture report which is showing E. coli and Klebsiella. The thing which went wrong, the bag sample was sent and you know it's a contaminant. It's a contaminated sample and your interpretation, everything done right is going wrong because of just improper collection, improper specimen here. Okay, so everything was right, the specimen was not right here. Not only specimen, the method of collection was the most important thing. Is especially in UTI. Now here, the child is febrile, 2 days, and the culture, the urine shows, the counts are little higher, borderline 10,000, CRP is borderline 22, 8 pus cells in urine routine, E. coli, colony count 10⁵. What is your interpretation? How will you manage? These are common OP scenarios. Not very simple to address. Not very simple to address. There is thinking behind every question and every option to be chosen. So again, counts are suggestive of sepsis. Clinically, the child is having sepsis, but there is one catch. There is change, the child is afebrile for 2 days. Same child is afebrile for 2 days now. Counts are normal. CRP is borderline here and there, no use. 8 pus cells again borderline, whether we can call it pyuria or not. And you have got a confirmed E. coli colony count 10 raised to 5, which is diagnostic criteria for UTI. Is it UTI? Will you treat it? Appropriate. Whatever it is appropriate. This is not bag. You have got one organism with significant counts. This is not bag sample. You call it clean catch, you call it catheter, baby suprapubic also. Great. This is the pick. Will you treat this UTI? Again the same thing, definition. Clinical background, pyuria and culture positive from an appropriate specimen. This is going to define your UTI. Here the child is afebrile for 2 days. Without antibiotics. Without antibiotics, the child is afebrile. Exactly, self-resolving. You have got a UTI. Again, there are 2 different components here. The initial choice here, prima facie choice will be when it is self-resolved UTI. It is a confirmed UTI. It is self-resolved UTI. You don't need to treat it. You don't need to treat it. But the catch is, there is other angle to it. It's a 12-month girl, young infant. 2 days high fever. Here the chances of renal scarring are little high. So that's the only point. But this is not part of module, let me tell you. Let us take home message. If the child is afebrile with antibiotic, without antibiotic, continue the same or don't treat. If you have put on cefixime, the child is afebrile, it gives you ESBL, continue with your cefixime. Don't go with the... So again, culture has to be correctly done. Urine culture has to be interpreted in clinical background and the progression of the child's clinical condition. Okay? So right test, right patient, specimen sample collected in the evening and kept bedside and sent to lab next morning. So the second error done. You rightly said about method of collection, which was right, but the storage and transport defeated the purpose. Not a reliable thing. If you are collected in the evening and given to the lab in the morning, it's hardly of any use. A contaminated sample, a sample where there are some organisms are going to grow over that time. So not only collection, storage and transport is the important component which will tell you whether this is right specimen or not. Okay? So, again we come to the first component, right test, pretest, probability, performance, characteristics, specimen, storage, transport. 3-year boy, high fever 2 days, throat pain, right-sided Krebs, mother has H1N1 infection, X-ray, CBC, blood culture, throat swab, PCR. Answer it. 3-year-old boy, high fever 2 days, throat pain, ILI. Influenza-like illness. With family history of influenza, mother had recent confirmed influenza. Right-sided Krebs the child is having possibly a pneumonia. So this is clinically, this is mostly influenza, pneumonia with the epidemiological background of recent H1N1 in family. So these tests are done. Let us look at. X-ray, diffuse infiltrates, counts normal, then platelet 1.2, blood culture no growth, throat swab PCR, influenza not detected. Is this not influenza is the question. Again same, right patient, right time, right test. So the question is here about throat swab PCR. It is highlighted. The question is about this test. Is it a right test? Is it a right time? And is it a right interpretation, performance characteristic of this test? Unless you know of this PCR, throat PCR in influenza, you cannot answer this question. It has come negative. You ordered it. It has come negative. तो आपके पास क्या है? The parents will ask you, is it not influenza? Answer them. Again, the question is, which specimen it is? You are looking at influenza, pneumonia as well as influenza. The throat swab is reasonably reliable. For pneumonia, you have to have lower respiratory specimen, not the throat specimen. Okay? So the site is correct, the specimen is correct, pretest probability is very high in this child to be influenza. Where can the problem be? The problem in the test itself. Is it a good performance test? So everything is, you have already started oseltamivir, are you going to stop it? That is the question. No, you are going to continue it. It is the right test, right patient, right time. Flu PCR sensitivity is not 100%. So what went wrong? The performance characteristic of this test. We don't know much of it. It's not 100% sensitive. Everything is there. Clinically, it is like influenza. You have started treatment. You are going to continue. So doing this test in this patient is not a right choice. Exactly, that is what is being done. And again done, it is not 100% reliable. So otherwise also you are going to treat this child as influenza. You have started oseltamivir, you are going to, so doing this test adds nothing to our therapeutic options. This is the message. This is the message. Only hospitalized children, critical children, you need to send it for confirmation. If you are treating it with oseltamivir, which is a standard recommendation everywhere, every high-risk patient on OPD and all hospitalized patients of suspected influenza have to be treated with oseltamivir. This is the recommendation of National Health Agency. We have to go ahead with that. Okay? So the test is not very good. Okay? So proper interpretation again is very important. Okay? So right interpretation matters a lot for safer, effective and efficient decision making. 10-year-old boy, dengue shock syndrome in ICU for 7 days, ventilated, starts spiking again. Dengue shock syndrome, is ventilated, is 7 days in ICU, gets a new onset spike. Blood culture sent, PIPTA started, gram-negative bacilli, growth is the initial report of micro lab. Identification and antimicrobial susceptibility tests are awaited. It takes additional 24 to 48 hours. So what are you going to do in this child? Clinical scenario is there and it turns out to be Klebsiella pneumoniae. You have started PIPTAs, changed to meropenem. Is it right? Is there anything else you can do? This is little higher, especially ICU people will be asking this question. They have to know this. This is a typical high-risk, prolonged illness, serious illness patient having secondary new onset bacterial disease, sepsis, okay, which is Klebsiella. The child is already on antibiotic. PIPTAS is very good first choice for GNB. You have changed it to meropenem. Is it right or wrong? Is there something additional information you will need in this case? A child is critical and having hospital-acquired infection mostly. Let me tell you, there is no other complication. You have got Klebsiella isolated on the blood culture. There is no other associated comorbidity. There is no VAP. This is sepsis. This is hospital-acquired sepsis. We have got the organism isolated. Exactly. The question to be answered, is your change from PIPTAS to meropenem going to be effective here? This is the key question here. The child has gram-negative sepsis, which is healthcare-associated infection. Is your choice of changing second-line meropenem correct or not? Do you need to do something else to answer this question precisely? It is going to take 24 hours. Is there anything else you know which can be done? So there is a new test. Expert Carba-R is the test which is available in all the centers, which helps us in gram-negative antimicrobial therapy very specifically. My personal and humble request, please use it. It is mandatory before you are treating such a critical child. You can't treat such a critical child empirically with meropenem or any other agent. You have to have precise diagnosis. You have got a GNB here, dear, and the Carba-R expert report comes in 2 hours or 3 hours, which can guide you about the next agent. agree with you with, it is, see, again you are mixing up the stewardship with the cost. It's not a question of cost. This is a critical child, hospital acquired infection, waiting for 24 hours can kill this child. No option, do it. Just don't hypothesize or think of what will come when you do. Here you have no choices. You have to treat this child aggressively, proactively. Here you have to do carba. There are few organisms where carba is useless also. So Acinetobacter is not going to help us. GNB can be Acinetobacter, but we have got Klebsiella here where carba R expert is definitely useful. Definitely useful. And you have to do carba R expert. This is definitely indicated. Carbapenemase resistance will be available after 24 hours. You don't have that much time in this child to wait for. You don't have that much time. Here you can't wait and treat the child as the reports come. Okay? So by that time, the molecular test expert carba R is ordered, which is a set of five resistance gene mapping, which will tell specifically which next line antimicrobial agent is to be chosen. It's not empirical, the things are different, all the genes are different, and depending on the results, it will guide you whether it is going to be ceftazidime avibactam alone or a combination of ceftazidime avibactam plus aztreonam, as in case of NDM, which is common resistance gene, CR gene in India. Abroad, it is the other ones, OXA and VIM and all those where your ceftazidime avibactam alone can be effective. In India, we have NDM, which has to be a combination. Again, this test is specifically going to guide you about selection of such a highest level antibiotic for such a critical child with the odd multi-drug resistant organism. So this is the highest scenario where you can't err on going empirically. You have to do the test which is available, and definitely it is going to guide you about the. So the meropenem MIC was 16. Next day we get the report. It is resistant. Ceftazidime avibactam and aztreonam started. Molecular test to improve diagnosis and shorten turnaround time. Again the message is here. Let it be 15,000. It is not equated to the life of child and the critical scenario. Don't mix it up with cost. Think about your CBC, CRP, urine routing. You are doing right and left so many times. The cost is more in that, doing routine investigation. These are very vital tests. You have to spend, rather you have to counsel your patient to invest in these tests which are going to be crucial to save the life of child and to make right, rational, life-saving decisions of antimicrobial therapy. Okay, so RRR, again we come back to the same diagram, not to be confused with cost effective. 1-year-old girl in shock, fever one day, blood culture drawn, Vancomycin started, CBC, CRP, urine routine, lab informs urine packed with pus cells, Vanco stopped, non-ESBL E. coli is the culture report. De-escalation to ceftriaxone, discharged on cefixime. This is beauty of diagnostic stewardship. What was bad on day one? The child was septic, shock. We started with empiric cover, rightly so. Vancomycin, we don't know the organism. It turned out to be UTI, gram-negative. Then we stopped Vanco. Then we got ESBL, non-ESBL E. coli on culture. We de-escalated Mero to ceftriaxone. The child became febrile. We further de-escalated to oral cefixime and discharged the patient. Only because of right test in right time with right interpretation. This is just to tell you what is the beauty of diagnostic stewardship. Okay? Blood culture before antibiotic, yes, was sent in this child. Results communicated in time. Everything done rightly. Blood culture was sent before antibiotic in this thing. Right test, right time, right patient. Results communicated in time by lab. Right interpretation by clinician. Diagnostic stewardship done, and antimicrobial stewardship purpose served. De-escalation 1, 2, 3, highest level antibiotic empiric, then coming to single gram-negative therapy, then coming to lower level with susceptible organism. So this is how it explains how DS works. So it requires multidisciplinary collaboration. A clinician and microlab are the essential thing. You may have ID, intensive, it can be a clinician or intensivist, but microbiology lab is the essential component, and you have to ensure that it is the right lab. It is an accredited lab. Standardization, validation are done with utmost care. Please look at that. Don't blindly rely on your microbiologists. Counter questioning, counter checking is a must for us. Don't accept any test brought. This is a new test. Don't go for tropical fever panel on day 2 with 5,000 giving all the diagnosis to you. Please don't do that even if promoted by your microbiologist. Ask questions to your microbiologist. Okay? So this is the sequence, how it does. So pre-analytical section, history, physical examination, clinical impression, specimen collection, test order are the parts of pre-analytic diagnostic stewardship. Tests performed, the laboratory, the method, accuracy, standardization are the analytic factors, and post-analytic is proper reporting, proper interpretation and treatment prescribed. This is post-analytic component of diagnostic stewardship. And finally, we are going to antimicrobial stewardship. Everything you have to look at, all these things are very important. So, is very important, right test, right patient, right time for suspected infection patient. All the tests, not only lab tests, and highly sensitive novel diagnostic should not replace clinical input and basic. So, there is no option to clinical background which increases your pre-test probability. We must train ourselves in effective principles of diagnostic stewardship. Let us focus pre-test probability based on clinical impression, representativeness of your specimen from the site of infection, collection of the specimen before antimicrobial therapy, then previous antimicrobial therapy has to be entertained. There has to be a protocol or algorithm. Then samples that will provide useful and accurate laboratory results should be sent. Avoid contamination. Reach the laboratory without any delay and interpret everything. We are going to land into diagnostic stewardship as well as antimicrobial stewardship. Thank you.
Actually, from Dr. Hirekeru sir.
Very excellent coverage of all different scenarios. Thanks for that. So my question is how often, in which cases specifically we will send CRP? Because CRP is taken as a license to start antibiotics. No, it is not objection, it is observation. Okay. Because not all patients of pneumonia will land into a scenario of cytokine storm, say. Not all cases of typhoid will land in a scenario of cytokine storm. And it is that situation where CRP will help. For example, the first case, the fever was only for 3 days. So I probably might not have sent CRP. I might have collected a sample, of course, and sent, because it costs 450 rupees. Secondly, regarding the carbar, growth of organism itself takes 72 hours. And then in next few hours, we get the sensitivity report. If my patient means yes, no, yes, flag they will. Yes, there is a first. Yes, that depends on the how much load of organisms is there. Especially for Staph aureus and MRSA, they will flag early. In 24 hours. Staph aureus, MRSA takes very early. Yeah, yes. So in that case, that is a different thing. My question is that CARBA-R, doing CARBA-R means we are in a scenario where patients may not agree to that. That's what I am putting it. That's the reason. If the patient is in shock, I might not wait for even sensitivity report. I will start what you said as astronomy, and we have done that already. If patient is in shock, but if patient is just spiking and otherwise it is okay, then we might not do this test, wait for the sensitivity report. If there are more than 2, it is resistant to more than 2 carbapenems, that is the situation where I would do it.
Vikram, I fully agree with you. The thing is, we are giving carry home messages.
Okay.
And the gravity of the issues and decision making are always interconnected. Here, what I again said about this is a child with us for different problem. This is a hospital acquired infection. The child is in sepsis where everything becomes very crucial. And you know, hospital acquired sepsis is highly likely to be MDRO. highly likely to be. And the current resistance reported by ICMR and all agencies in India, GNB, MDRO is more than 70%, where facing carbapenems producing organism is a common scenario. You just can't wait for, in such a child for 24 hours to get whether it is susceptible to carbapenem or not. And about the cost of test, I told you, and this is not an option for patients. Carba or expert is our option, our selection, not the patients. Not the patients. It is our selection and we have to select it. The message here is look at the gravity and the scenario and then do it. I fully agree with you. There are some gray areas about the timing of it, whether you can wait or not, and seriousness of the patient. I fully agree with you. I agree with you.
And second is fever for 1 day, CBC and CRP. This is a blanket thing.
Let
Are
me tell
going
you,
to address
I'll address that also. CRP we are dealing in
because
detail.
for the first case I would not have sent. Maybe in between one case also
Because
I would not have sent.
आता काय माहिती काय
But this becomes a message.
हेअर स्प्लिटिंग करायचं
Then
नाही.
hair is
Everybody
not
of us
No,
सांग
I'm sorry if I'm doing that, but it is not hair splitting. The thing is that message is given.
No,
And
I'm
it will
talking
be done.
Yeah,
That's what
I'm
I'm
talking
saying.
about the decision of doing CRP.
Yeah.
We are
If
doing
you are going
hair
to
splitting
address
also.
it, it's okay.
I respect you if you are not doing it. Let me tell you, I also do CRP on all cases because we'll deal with that in detail. It's a basic sepsis screen. It has got its own value in helping us in common fever without focus of short duration also. We'll deal with that.
Thank you, sir. Our next speaker, Dr. Aishwarya ma'am.
A very good morning to all the respected teachers and seniors. I'm Dr. Aishwarya Kulkarni. So I'm here to deal with diagnostic stewardship and short duration acute febrile illness. So what comes in your mind when I say short duration acute febrile illness? Anyone? Any conditions? I mean, sorry, but I'm asking questions to all the seniors, but you have to answer me. So, viral infections which are routinely coming into our OPD. Anything? Dengue, malaria, chikungunya, adenoviral infections, influenza, or just a sore throat. Everything comes in short duration acute febrile illness. So let us start with this case scenario. This is a 2-year-old girl who is brought to you in the OPD for the first time. She is having high-grade fever since previous morning. So this is just 1 day of fever. She is less playful than usual. There is some loss of appetite. She is eating less than normal, and the parents said there are no other symptoms. So, what is your approach in this case? So, what do you think it is? So, you will just reassure the parents and ask them to and just give antipyretic and call them in a day or two, or you will examine closely to look for any focus of infection. You will check the vitals, order some investigations like CBC, CRP, and just you want some more history from the parents, or the patient is non-affording, so just write antibiotics and send home.
You can have one or more.
Yes, you can have one or more answers. Yes? A, B, C, E. Okay. So definitely you would like to have some more history first, then you will check for the vital signs, and again you will look for focus of infection. So what more history you want from parents, if you say so? Yes. 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 Yes, sir, definitely. So basically, to keep in mind what epidemic is going on currently right now, like the dengue which is going on currently right now, influenza is there. So that will give you more idea to elicit your history. Then again you will ask similar complaints in the family members. If the mother is having cough cold, or sibling is having cough cold, father is having fever, rash, body ache, then that will again help you to go to your diagnosis. Then if the child is having previous an episode of UTI, urinary tract infections, or immune status of child is again an important thing. And lastly, again the comorbidities, if there is any congenital heart disease, then you will like to elicit this history. Then what vital signs you will look for in this child? So is the child alert, lethargic, or toxic? So that is very important, because your approach will be totally different for the child who is alert, playful, and for the child who is lethargic and toxic, your approach will be totally different. Fever is going to give you more idea about a basic idea regarding viral and bacterial infection. So the child is playful in between interfebrile period, it might be viral. And when the child is more drowsy, sleeping during the interfebrile period, then it is bacterial. But again, in the severe viral infection, the child may not be playful during the interfebrile period. Then how high is the fever? And whether the fever is, there is biphasic fever, the fever is coming, going and again coming, intermittent, continuous fever. Then tachycardia, tachypnea, hypotension, whether the child is dehydrated, how is the perfusion of the child, whether the CRP is delayed or CRT is normal. And again, after COVID, we all are having the pulse oximeters handy in our OPD, so it is always better to check saturation when the patient is coming to you in OPD. And then to look for focus of infection. So this patient is coming to you in OPD with your routine clinical examination. You have checked whether the patient is having pallor, whether the patient is icteric, you have auscultated the patient, and you have done per abdominal examination. So in this examination, what you are really missing? Anything else you want to look for? Apart from your auscultation, looking at the pallor icterus and per abdominal examination. Yes, so throat examination is must when you are looking at the patient with fever of shorter duration. You may sometime miss it. And another thing, anything more than throat infection? Ear examination, right? Or anything else? So any tender lymphadenopathy is there, any abscess is there anywhere in the body which patient or parents may not tell you, but you need to look for that focus as well. And again, at last, you need not miss the meningeal signs. So this is a 2-year-old girl. We are coming back to our case. We have done all the examination. We have got the vital signs, and we are done with the history and everything. So you want to investigate this child. So on which day of illness you really want to investigate? Day 1, day 2, day 3, day 4, day 5, or day 6? Anyone? Day 3. Okay. Any other answer?
Again, look at the clinical scenario.
Because the patient is coming on day 1, so you are sending the patient home and again calling the patient on day 3 to investigate. So it again depends on how the patient is. The patient is sick, critically ill, you need to investigate right there. So if the patient is immunocompromised, you will investigate immediately. If the patient is sick, toxic, obtunded, you need to investigate right now. Dangerously abnormal vital signs, and you have specific clues. You are seeing flushing is there, petechia are there, definitely you will investigate on the same day. And rarely for the infection control purposes, tests like COVID-19 may be carried out early in the duration of illness. So now you have decided to investigate. So what tests you will do? CBC, CRP. Apart from that? So CBC, then your acute phase reactant, CRP, then malarial parasite peripheral smear, rapid malaria antigen test, dengue serology, urine examination, blood culture, and serological tests like Vidal. So now we'll go one by one with these tests, and let us see how is your approach with these tests. So you have decided to do CBC first, and this is the CBC of the child. So the hemoglobin is 12.8, hematocrit is 38.6. WBC count is 10,800 with 72% neutrophils, 22% lymphocytes, 5% monocytes, eosinophil 1%, and platelet count is 1,80,000. So what is your conclusion from this CBC? Okay. Okay, viral-like illness. But the neutrophils are 72% here. Like adenovirus, yes. Yes. You cannot. So I can say this can be normal.
It is difficult to interpret. You have to corroborate with other evidences also.
Okay, so one can label it as this can be viral, one can say this is normal CBC. So again, it depends from individual to individual. So only CBC cannot give you whole clue about the diagnosis. So interpreting CBC in enteric fever, hemoglobin and hematocrit is normal. Malaria, it is low. In dengue, it may be normal or high. Again, it depends upon the stage of the disease. When you are doing the CBC, you are doing it in a febrile phase or critical phase, that is going to make a difference. And other viral infection, the hematocrit and hemoglobin will be normal. And even in suppurative bacterial infections, it will be normal. Regarding TLC, it will be normal or low in enteric fever, malaria, dengue and viral infections. And in suppurative bacterial infections, you may get high TLC count. Differential counts, polymorphs and BORs will be there in enteric fever as well as you will get it in suppurative bacterial infections. Eosinopenia is seen in enteric fever, monocytosis in malaria, in dengue fever and other viral infections you will get lymphocytosis. The platelet count will be normal or low in viral infections, and again for dengue it will differ according to the stage of the illness. Peripheral smear, you can check for malaria parasite. You may get abnormal cells in cases of infectious mononucleosis and ALL. Okay, so again, coming to your acute phase reactants. So which ones you will do? CRP or procalcitonin? Why? But it even comes positive in other conditions as well, like burns, trauma. It is there. So for procalcitonin.
So how many of you do CRP in OPD practice? How many of you do CRP in OPD practice? So with 3 days fever, a child comes to you, how will you interpret?
Sir,
Yeah?
it is just
Just a
to
prayer. No. So not taking
Not
in
taking
only
that
this
case.
clinical scenario. We are
Any
discussing CRP as a general. So in CRP as a general, if you are saying the CRP is not at all useful, how many of you do CRP in your OPD practice? Yeah, it's so supportive. Yeah. Sir, yeah, so we are not discussing regarding only this patient. We are discussing as a test CRP. So we all do CRP. The problem is only interpretation of CRP. As you said, rightly said, CRP may not be always positive in bacterial. See, 1 month child, high grade fever, 1 day, we need to rule out sepsis. So at that patient, definitely we will do. Yeah, I know, but CRP करना ही नहीं है. CRP is not at all useful. It's not. Okay, CRP, yeah.
Okay, so I am not discussing these tests regarding to this case only. I'm just discussing these tests for all the clinical scenarios. So CRP is cheaper. It is more easily available. It may be useful to distinguish between viral and non-viral infections. The problem here is the CRP is not giving you clear-cut cutoff that if 40 CRP is there, it is viral or it is bacterial. If you have 50 CRP, but usually CRP more than 80 is considered as bacterial, just to differentiate between viral and bacterial infections. Again, you can have very high
No, we don't
CRP.
have any. Yeah. 100. So, negative predict. To consecutive negative CRP will give you good value. Yes, that is. So there is no sacrosanct cutoff for CRP.
Okay, so even in viral infections like adenovirus and COVID-19, we can see CRPs more than 100 as well. So again, the cutoff is not well defined. But here is a concept of estimated CRP velocity. So what is estimated CRP velocity? Let us take a case scenario. A patient A and B is coming to your OPD. Both are having CRP of 100. The patient A is coming to you on 10th hour of illness. So just 10 hours of fever is there. And the patient B is coming to you on 100th hour of illness. So 4 days have already passed. So basically we have to calculate the CRP of patient A, that is estimated CRPV. So 100 CRP with 10 hours of illness, his estimated CRPV will be 10. For the 100th hour of illness, the B patient coming to you, his estimated CRPV will be 1. So the patient A is having more inflammation and more infection, and he is more likely to go into cytokine storm. So this is basically the concept of estimated CRPV. And there is one more concept, that CRP velocity. This CRP velocity is calculated when you are doing two different CRPs, that you are doing CRP on day 3 and day 5. If your CRP is rising, then definitely that is having a significance than a single CRP. So rising CRP is more indicative of infection than a single CRP value, and you can even calculate estimated CRPV as well. So this is regarding CRPV. Now let us go to the investigations for malaria and dengue fever. So for malaria, you have two tests available. You can do either peripheral smear, thick smear and thin smear, and you have rapid malarial antigen test as well. So what your thick smear is going to help you is to know the parasite load, and thin smear is going to help you to know the species of the malarial parasite. Again, you need not to do it at the height of fever. Any sample is okay for doing the peripheral smear. The rapid malarial antigen tests are useful when microscopy is not available and reliable. And you have two tests in that. You have parasite lactate dehydrogenase test, and the other is histidine-rich protein antigen test. So why to prefer PLDH test over histidine-rich protein is, PLDH is going to give you idea about falciparum and non-falciparum malaria, which is definitely going to help you in your treatment as well. And the other thing is, this histidine-rich protein test can come positive even after you have treated malaria for, even it can come positive for 2 weeks, even if you have treated the infection. So it's always better to prefer PLDH test. And when you have strong suspicion your first smear is coming negative, you do the rapid malaria antigen test, and you may repeat the smear after that as well. Falciparum malaria, and it will not give you about a non-falciparum test.
Live.
Live.
So that is
It's
that's
from the
fine.
cytoplasm of the P. falciparum, and LDH is from the asexual and sexual both stages of malaria, so PLDH should be preferred. So regarding dengue fever test, so what are the available tests we are having? We have PCR, we have ELISA test, we have CART test, like we have antigen detection and we have antibody detection. Again, for dengue fever, the tests should be decided depending upon the stage of the disease, the duration, the day of fever. So in first 5 days, viremia is going to be there, your PCR can come positive, and even your NS1 is going to come positive. Also, if there is secondary dengue, IgG is going to come positive on day 2 and from day 2 or day 3 of the illness. So you can do NS1 and IgG if you are suspecting secondary dengue or not, you can do, and if IgG comes positive, it is going to be secondary dengue as well. The day 4 and day 5, we call it as window period, because the NS1 is going to come down and IgM is going to rise. So your NS1 and IgM both can come negative. So that doesn't mean that dengue is not there, but it is a window period. For IgM, you can preferably do the test after day 5 of illness. The specificity of NS1 is nearly 100%, and 90% positivity rate is there in first 2 to 3 days in the primary disease, and 70% positivity is there in the secondary disease. Also about ELISA, NS1 specificity is very good, so if you have ELISA, you can very well do it, but NS1 is also very cost effective, the routine test, so it's better to do NS1, or if you want to do ELISA, you can do ELISA, there is no doubt in that. Regarding PCR, the cost of PCR is very high. So if you're really suspecting dengue, the patient is really sick and you want to prove your diagnosis, then you might order PCR for dengue, but not needed, as we have some better low cost tests which are very cost effective and giving good results. Then coming to urine examination. So urine dipstick test, which is going to give you idea about glycosuria, your leukocyte esterase, nitrite, and even proteinuria, are fairly reliable, and these are semi-quantitative simple dipstick tests. And this is the culture, this is the urine routine report. It is showing bacteria is present, pustules are 12 to 14, and nitrite is nil. So is this UTI, or what you will do? So this is confirmed UTI, and you are going to start antibiotics right here, or it is unlikely to be infection, just ignore. Repeat sample, send culture, wait for the report, or send culture but start antibiotic right now. Send culture? Okay. So considering this patient who is only 1 day ill, just not having much of the symptoms, not very sick, so what you will do? Yes, nitrite is negative. Okay. But again, they are showing.
Again, performance characteristics. For nitrite to be positive, you have to urine to dwell in the bladder for long.
4 hours, more than 4 hours.
So young infants
12 to 14 pustles per high power field. So in this child, it is better to send culture and wait for antibiotics since the child is only having 1 day of fever. So just interpretation of urine routine, pyuria more than 5 WBCs per high power field in a direct sample and more than 10 WBCs per high power field in a centrifuge sample. The specificity is 48 to 82% and the sensitivity is 70 to 85%. Regarding nitrite and leukocyte esterase, they have very good specificity. But when you combine these two tests, the sensitivity again increases. So if you interpret positive leukocyte esterase, positive nitrite, and even if you have pyuria as well. So all these three tests coming positive is very good indicator for your urinary tract infection. Then gram stain in a fresh sample collected for urine culture, it is having sensitivity of 93% and specificity of 95%. So basically what we learned in the first lecture, that right specimen, right storage, right transport, this all is going to apply for your urine routine and urine, mainly for the urine culture, because the sample collection method is very important when you are doing checking the reports for urine routine, urine and urine culture mainly. So bag sample is usually useful for your dipstick test and urine routine, but it is not really good for your culture method. Then clean catch and midstream urine samples are very well useful and they have good results. The suprapubic collection is the ideal method, but it is invasive, so it is not preferred. And catheterization. So not from the urinary catheter which is already there, you need to catheterize the patient and then take the urine. That sample is also a good sample for your urine culture. So we have done urine culture and this is the culture report which is saying E. coli is there. The colony count is more than 10⁵ and it is non-ESBL. So whenever you see this culture report, what questions you want to ask? Anyone? Or you will just start with the antibiotic and you are happy with the culture report, this is UTI, you are starting antibiotic, that's it. So what you will ask for? Time of transport, yes, definitely you need to know, because the sample which is kept at room temperature should be transported within 1 to 2 hours and the refrigerated sample within 4 hours, right? And another question which I just discussed, method of sample collection. So that is very important because the cutoffs are dependent on the method of collection. So is this UTI confirmed? No, you need to know the method of collection because your suprapubic puncture is having 100% specificity, catheter samples, clean cat samples, midstream samples, everyone is having specificity of 100%. The catheter sample is having sensitivity of 95%, bag specimen 77%, and clean catch it is 90 to 97%. So again, the question you said, how long the sample was stored before reaching the laboratory? That is very important. Never use bag sample for urine culture. It can be used for your dipstick and urine routine, but never for urine culture. Again, the cutoffs are, the colony count is again depending upon your sample of collection of urine. So clean catch and midstream urine, the cutoff is 10⁵ colony forming units per ml. But nowadays, there are studies which are mentioning that even 10⁶ to 10�7 cutoff is considered for your, labeling it as a significant colony count, and the probability of infection is 90 to 95%. For catheter samples, the cutoff is 10⁴ colony forming unit per ml, and the probability of infection is 95%. Suprapubic, any pathogen you are growing, irrespective of the colony count, it is definitely a positive culture, and it is 99%. Symptomatic patients, even 10⁵ to 10⁵ per ml is the cutoff. So 10⁵ is not a sacrosanct figure of cutoff to diagnose urinary tract infection. Now after urine routine and urine culture, let us come to blood culture. So you decided to send blood culture of this patient and it has shown growth of Staphylococcus albus. Yes, definitely, it is a contaminant. So you will start cloxacillin now, it is there in the report. So you will start cloxacillin, you will await the sensitivity report. This might be MRSS, or start linezolid, ignore or repeat the sample. Yes, ignore, because the patient is not really sick and you need not to repeat the sample as well, and this is contaminant. So coagulase negative staph is usually skin colonizer, and it does not fit into the clinical condition of the patient as well. But when this Staphylococcus albus you will consider as a pathogen and you want to treat it. So in which condition maybe you want to treat this? Yes, immunocompromised child or the child who is having intravascular devices. And how to reduce this contamination, or how to know that this is not a contaminant and this is a true pathogen. Is there any change in method, or is there anything you want to do while collecting blood culture? Collection method should be proper, that is one thing, and two sites of collection is very important. So a sample collected from two different venipuncture in a same time frame and is growing same organism. Then if that organism is growing, then there is only 1 in 1,000 chance that the organism is your contaminant. So the collection is very important. Always collect two samples from two different sites in a same time frame. A single isolation is almost have 0% positive predictive value. And since we have discussed that there is no indication for repeat blood culture and no indication of antibiotics as well. So few messages regarding blood culture: always collect in sets. If possible, send before starting antibiotics. Clean collection technique is must, and you have to send adequate samples with blood is to broth ratio 1:5. Transport immediately to lab, don't refrigerate before sending. And don't blindly treat positive reports. If the culture report is saying Staphylococcus aureus, Streptococcus pyogenes, Galacticeae, Streptococcus pneumoniae, Pseudomonas, Candida, E. coli, Enterobacteriaceae, definitely they are positive. More than 90% of the times these are the pathogens and they are the positive reports. But when you are having Corynebacterium or like Staph albus, the skin commensals, they are likely to be contaminants. Okay, so after blood culture, let us come to the serological tests like Vidal. So this is the Vidal report. O titer is 1:80 for Salmonella typhio and H is 1:40. So is this typhoid? So the methodology is also important. We have slide test and we have tube test. The slide test is having high sensitivity, so it is usually used for screening purpose. But when you have positive slide test, it needs to be confirmed with tube agglutination test. And it is very important to read these notes which are written below the your Vidal test reports, which we usually forget and just read the titers and just prescribe antibiotics and treat it like a enteric fever. So basically, titers more than 1:80 for O antigen and 1:160 for H antigen in Salmonella typhi, and titers more than 1:80 for H antigen in Salmonella typhi A and B are significant. Rising titers taken 7 to 10 days apart are more significant than a single Vidal test. Reactive results indicate ongoing or recent infection by Salmonella species, and the diagnosis should be confirmed by gold standard, which is definitely blood culture, before you start antibiotics. The reactivity will vary with stage of the disease, with appearance in first week to increase the titers till end of 4th week, post which it starts declining. In a post-vaccinated patient, high titers of H antibodies will be seen. They will be more than 1:60, and these titers will be persist for months to years. But for O antigen, these titers are lower and they will disappear in 6 months. Antibiotic treatment during first week before the appearance of antibodies tend to suppress the immune response in the form of no or decreasing antibody titers. False positive results may come when the patient is having past enteric infection or during unrelated fevers like malaria and influenza in the form of transient rise in the H antibodies in Vidal test. And false negative results may be due to processing of the sample collected early in the course of disease. So these are the main points we should keep in mind. Typhoid, very low sensitivity and specificity.
Any serological test
is having very low sensitivity.
Gold standard is blood culture. Any serological test in enteric fever is not recommended, as sir said. So the message is clear that the test itself has so much fallacies below the report. They have provided, the lab has provided report and they have mentioned 7-8 points that असं असेल तर हे, असं असेल तर हे, असं असेल तर हे, असं असेल तर आणि तुम्ही बघा काय करायचं. So जर एवढं त्याच्यामध्ये fallacies आहे, then why to do? Okay, so the message is clear. Of course, if at all, sometimes if you have to do, then just do it properly, but don't do it at all. Depends on timing. It's okay. So that is the okay. Now the point is taken. It's okay. So we will discuss that point. I know the sensitivity of blood culture is low. See, that's what Vidal. Vidal, if it at all has to be done. If you are pushed to the boundary of wall, say the child has 2 weeks of fever. Okay. Now at the end of 2 weeks of fever, there are, as you said, blood culture is very less likely to come positive. Okay. In that scenario, in that certain scenarios, yeah, then you have to clinically treat. And unless and until very in that scenario, you can have Vidal, but use it wisely. Don't do it.
Practically, the child is already being treated with antibiotic for 2 weeks. The child has already received. On the contrary, it rules out typhoid. If ceftriaxone or any routine antibiotic, the child has not responded. Over 7 days, it says it is not typhoid. And in this scenario, I will not do Vidal. I will go for bone marrow culture. I will go for bone. If you are typhoid of the ceftriaxone resistant. So many typhoid. Ceftriaxone resistant. How many years is it? It's a rarity. I just send me the report, I will publish it. We will publish it. It's rarity. It's not at all a common thing.
See, the problem is.
Is a rarity. There are absolutely 1 or 2 cases. 1 or 2 cases.
We have to wait 7 days for defervescence. Minimum 7 days of ceftriaxone. We have to wait for fever to disappear. Don't label it ceftriaxone resistant before that. Wait for full dose of ceftriaxone for 7 days. And after that, if you are strongly suspecting enteric and it has not responded, then you can think. But at least minimum 7 days of ceftriaxone has to be given.
That culture helped you to tell it is resistant.
So the serological tests are not superior to the direct identification of organisms, useful only after first week of illness, so very less useful for short duration of fever. Need to be carried out with correct technique. Quantitative tests are always better, so you need to know the titers. Beware of cross-reactivity. Useful when organisms are difficult to grow or infection is in an inaccessible place. Check sensitivity and specificity before interpreting any serological test. So coming to a bit of community medicine knowledge, maybe some bunked lectures, sensitivity, specificity, positive predictive value and negative predictive value. So what is sensitivity of the test? It is the percentage of patient with disease who have abnormal results. Specificity is the percentage of patients without disease who have normal tests. Positive predictive value of patient is the percentage of patient with abnormal test results who have disease, and negative predictive value is the percentage of patients who have normal test results who don't have disease. So this is a bit complicated. Let's just simplify it. So this is where A is having disease and his test is also coming positive. B is not having disease but his test is coming positive, so that is false positive. C is the number of patients who are having the disease but the test is coming negative, so it is false negative. And D, these are the patients who are not having the disease but the test is coming negative, so it is true negative. So what is sensitivity? It is true positive divided by true positive plus false negative test. Specificity is the true negative divided by true negative plus false positive. What is positive predictive value is the test is coming positive, that is true positive, divided by the true positive plus false positive tests. And negative predictive value, it is the true negatives divided by true negatives and false negatives. A good test is the one which is having highest sensitivity and specificity, but it need not necessarily translate to your positive predictive value. Because your positive predictive value, as sir is telling right from the beginning, it depends upon your pre-test probability. Suppose I am having a test which is having 90% sensitivity and 90% specificity. Let us take example, you are having a neonate with neonatal hepatitis and you are suspecting toxoplasma in that case. The baby is really not having any other intrauterine insult, stigmata, and you still want to go with toxoplasma IgM in this case. So definitely your pre-test prevalence is very less, even though the IgM test is having sensitivity of 90% and specificity of 90%. Your positive predictive value is going to be only 50%. But when you are doing a test where your pre-test prevalence is 50% with high sensitivity specificity, your positive predictive value is definitely going to be high, that is 90%. So this is very important. When you have low pre-test prevalence, it's better to avoid the tests because your positive predictive value is going to be low. When you have high pre-test prevalence, your positive predictive value is going to be very high. So positive predictive value tells how many patients with positive test are actually having the disease. Negative predictive value is just ruling out the disease. Positive predictive and negative predictive value change with prevalence or pre-test possibility, and hence it is very important to have high possibility of the diseases before you are ordering any test. Coming to the tropical fever panel, for malaria we are already having peripheral smear and rapid malaria antigen tests. They are cheaper, they are more they are having good sensitivity and specificity, so better to order them. NS1 is 100% specific and it is highly sensitive. Enteric tropical fever panel is not validated. For leptospira you may use, but you can use singleplex PCR test as well instead of using this multiplex PCR test. And for rickettsia it is not standardized. We have scrub IgM ELISA, and even in Solapur we are having rickettsia gonorrhoeae IgM ELISA as well. So use single test instead of using this tropical fever panel test. But if you really want to use this test, you can use it in very sick child, immunocompromised, and otherwise if your all other tests are coming inconclusive, then you can go ahead with this tropical panel test. Because they are more expensive, that it is waste of resources, you have some better cost effective tests, so let's go ahead with those tests. Thank you.
Hello. Thank you, madam. Now I request Dr. Keyur sir for dealing further.
So we will go into systems now. Just for UTI, there is one good app, UTI calculator by Pittsburgh University. So it is very easy on mobile. You can put the values, the age of the child, sex of the child, whether uncircumcised or circumscribed. So it will give us good, pre-test probability of whether the child is having UTI or not. So in respiratory tract infections, this is the most common OPD patients we see. This is the anatomy of respiratory tract. We have nasal cartilage, vestibule, turbinate bones, nasopharynx, tonsils, oropharynx, epiglottis, laryngopharynx, esophagus, larynx, trachea. So all these sites can be involved in respiratory tract infections. So if terminate and bones are involved, we can have rhinosinusitis. Then we can have adenoidal hypertrophy, otitis media, ASOM, chronic ASOM, otitis media with effusion, tonsillitis, chronic recurrent, retroparyngeal abscesses, epiglottitis, laryngitis. So there are there is large spectrum of diseases associated with upper respiratory tract infections. So we'll come to what common clinical syndromes we face in our OPD practice, depending on the site of infection, and what may be the etiology and what test you may think of ordering. If the child is having coryza and rhinitis, what may be the commonest etiology? Viral or bacterial? Viral. So will you order any test for coryza rhinitis? No. Pharyngitis, tonsillitis? Etiology? Viral or bacterial? Croup, laryngitis? Viral, okay. Epiglottitis? Bacterial, usually bacterial. Otitis media and mastoiditis? Bacterial. Sinusitis? So this is coryza, rhinitis, it will be purely viral. Pharyngitis, tonsillitis can be viral or bacterial. Croup laryngitis is usually viral. Epiglottitis is usually bacterial. Otitis media and mastoiditis viral or bacterial. Sinusitis viral or bacterial. So for coryza and rhinitis, will you order any test? None test should be ordered. For pharyngitis, tonsillitis, Yeah. Sir has rightly said, rapid antigen test, if available easily, we can go for group A streptococcus. And molecular tests, throat swabs, smear cultures are available, but only certain scenario you can use them. Not necessarily you can use them, but you can use them. But for other croup, epiglottitis, otitis media, sinusitis, these are all clinical diagnosis. Okay, we have to diagnose them clinically, and we can start treatment clinically only. So, what are the most common bacteria associated with upper respiratory tract infection? Streptococcus, H. influenza B, Moraxella, sometimes staph. So, what are the viruses associated with upper respiratory tract infections? Rhinoviruses, influenza, herpes group, adeno, coxsackie, enterovirus, hand foot mouth disease, Epstein-Barr virus, measles. So, these are the commonest viruses and bacteria associated with the upper respiratory tract infection. So, how we will see any upper respiratory tract infection child comes to our OPD, there will be different clinical scenarios, and how we can have a clinical diagnostic stewardship. We are having a 4-year-old child with fever for 102 degree Fahrenheit for 2 days, watery red eyes, nose, some dry cough, not breathless. So will this be viral or bacterial? Viral. Why, sir? Yeah, so other mucosal involvement is there. So the watery red eyes are there, nose is stuffy. So some dry cough. So other mucosal involvement is also there, short duration of fever, not breathless. So viral etiology. 13-month child with 3 days fever, mucopurulent nasal discharge, excessive crying at night, unable to breathe properly, no tachypnea. So never forget to do the otoscopy. Okay, so I think we all have otoscopy in our OPD, but not all we take efforts to do otoscopy, because it is sometimes difficult to do otoscopy in crying child, irritable child. We have to restrain that child properly, and we have to do otoscopy properly. So if you have done otoscopy properly, you could have found that there is definitely on otoscopy we can see that this is otitis media. So this will be bacterial in origin. 8-year-old girl, fever off and on with purulent nasal discharge for 9 days, tenderness on cheekbones. Bacterial. Fever for 9 days. So fever is for longer duration, tenderness on cheekbones. So this is definitely sinusitis. So we will think of bacterial more. 6-year-old boy, fever 102 degree Fahrenheit, throat pain, odontophagia, ill looking, hardly any cough, no tachypnea. So it's difficult to differentiate. 6-year-old boy, fever for 102 degree, throat pain, odontophagia, ill looking. So in this child, it may be viral or bacterial also. So it's difficult to interpret. Okay. So it is not sacrosanct. No, it is not sacrosanct. So it's difficult to. In this scenario, it is difficult to interpret it, whether it is viral or bacterial. You may think of doing investigation in this scenario. So this is the picture, if you can see clearly. So it is viral or bacterial. So to differentiate between viral or bacterial, we have got modified central scoring system, and it is to decide the need for rapid antigen detection test or use of antibiotics. Now what is modified central scoring criteria? They have different clinical symptoms, like fever, they score 1 if fever is there. Tonsillar exudates, score is 1. Absent of cough, fever is 1, score is 1. Anterior cervical lymphadenopathy, 1 score. Age between 3 to 14 years, 1 score. Age between 15 to 45 years, 0 score. Age more than 45 years, -1 score. So score can be from 0 to 1. Of course, it can be -1, but it can be for practical purposes. For pediatrician, it will be 0 to 5. So this deciding need for diagnostic test and antibiotic treatment is based in acute pharyngitis. We can use this modified central score. If the score is 0, then risk is very low. No further testing, no antibiotic is indicated. Risk is, the score is 1, then we have 5 to 10% of group A streptococcus pharyngitis. But still, for 1 score, no further testing, we can wait. No antibiotic to be started. For score 2, they say that the risk is 11 to 17% having group A streptococcus pharyngitis. Here we can perform throat culture or rapid antigen test if you have. And if it is positive, then you can start with antibiotic. And if it is negative, then we can wait. No need to start antibiotic. If the score is 3 same, you can perform the throat rapid antigen detection test, or you can do throat culture. And depending on the test positivity negative, you can start directly with antibiotic, or you can wait. But if the score is 4 or more than 4, then you can consider starting empirical antibiotic treatment in this scenario. So in this way, this central scoring will help. We had a large epidemic of group A streptococcus pharyngitis last year in Pune. I think it was everywhere. all over Maharashtra, all over India was there. So we saw, yeah. We saw so many of scarlet fever. So in this scenario, in those scenario, this center scoring would have been more useful for us to decide whether to start antibiotic in those patients or not. So what are the almost common signs and symptoms in upper respiratory tract infections? Fever, coryza, cough, throat pain, myalgia, rash, orofacial lesions, and then lack of tachypnea and respiratory distress, more in URI. URI are almost always due to viruses. 90% of URI are viruses. No need to start antibiotics. Bacterial throat infections are only 10% of all URIs. Okay, so that 10% is also doubtful in our OPD practice. Okay, 10% they have given based on certain studies they have conducted, but almost all URIs are viral in nature. No laboratory investigation required except for streptococcal sore throat. Rapid antigen test, if available, we can do it. It has, but the test has to be done with proper method. We can have a throat swabs or throat swab culture also. But antibiotics only for proven bacterial throat, otitis media, acute bacterial sinusitis, epiglottitis as per the guideline. So for upper respiratory tract infection, we hardly need antibiotics. So we will discuss cases in short. 2.8-year female admitted with fever, cough, cold, breathing difficulty for 2 days on ceftriaxone. Transferred to higher center because of no improvement and dissatisfaction. Was sick for 7 days prior to hospitalization with interstitial lung illness, febrile, tachypnic, saturation is 88%, bronchial breathing, right axillary and infrascapular region with bilateral crypts. So what is our clinical diagnosis? So this is severe pneumonia. Okay, so how we will start treating this? Which antibiotics? Of course, use of antibiotic or which antibiotic is not part of this stewardship, but just two. This is severe pneumonia. Which empirical antibiotic? Community acquired pneumonia, we start with ceftriaxone plus cloxacillin to cover staphylococcus. Now, this is the case from north. Cloxacillin is not sometimes available in our scenario, but they have started, whoever the case has discussed, they have started with ceftriaxone, cloxacillin to cover the staphylococcus. So what investigations? We are here for investigations. So what investigation we will send in such child? CBC we will send? Because most of the community acquired pneumonia, children are bacteremic pneumonias. Okay, so they will have bacteremia also. Okay, so CRP is 13.21. Blood culture? Blood culture recommended for severe community acquired pneumonias due to greater chances of being bacteremic pneumonia. So blood culture, if severe pneumonia is there, we have to send. Also for healthcare associated pneumonias, for some reason, same reason that there may be bacteremic pneumonia and plus risk of unusual and multi-drug resistant organisms. So if there is severe community acquired pneumonia, it is good practice to send blood culture also. Any molecular test in community acquired pneumonia you will order? Do you do respiratory PCR routinely for community acquired treatment, community acquired pneumonia treatment? So, not needed, because see, if you do, as previously there was a case, if you do in lower respiratory, this is the wrong site for the wrong region, because we are having low respiratory tract infection, and if we say in biofirepin upper respiratory tract, we may land into the problem. So या टेस्टचा आपल्याला त्रासच होईल, कारण या टेस्टमध्ये समजा त्यांनी त्या पेशंटची पाठवली and they got human rhinovirus detected, parainfluenza virus detected. So आता ते आले तर काय करणार? सो ते आल्यावर प्रॉब्लेम करणार, पाठवायचीच नाही, पाठवून डोक्याला ताप कशाला करून घ्यायचं, कारण त्याचं आपण करणार काय आहोत? पेशंटला एक्सप्लेन काय करणार? पेशंट म्हणा सर आलं ना त्याच्यामध्ये, आता काय करणार तुम्ही? सो if we are not going to use that test, why to send that test? Okay, and it is very costly test, so why to send? So what are the limitations of multiplex PCR biofires? A positive test only indicates nasopharyngeal presence of the bug, but a sample in minibal or bal compares favorably with pneumonia. So at all in severe community acquired pneumonia, you want to corroborate the multiplex PCR, then you have to send the respiratory panel, low respiratory panel. Then तुम्हाला bronchoalveolar lavage करायला पाहिजे किंवा minibal तर चाइल्ड इंट्युबेटेड आहे तर मिनीबाल करायला पाहिजे. मिनीबाल इज दॅट मीन्स दॅट यू हॅव टू pour some normal saline and you have to aspirate those secretions, send it. Okay, so mini बाल केलं असेल आणि त्याच्यामध्ये जर ते पॉझिटिव्ह असेल देन इट इज सिग्निफिकंट. अपर रेस्पिरेटरी ट्रॅक मधनं पाठवलेलं पॅथोजेन तुम्ही लोअर रेस्पिरेटरी ट्रॅक इन्फेक्शनसाठी कोरिलेट करू शकत नाही बिकॉज इट कॅन बी बायस्टँडर ऑर अन ॲक्च्युअल पॉझिटिव्ह वी डोंट नो. मल्टिपल व्हायरसेस आर ऑल्सो फिडबॅक. एका वेळी 2-3 व्हायरसेस ऑर्गॅनिझम डिटेक्ट होतात. कुठला खरा धरायचा? Multi-center studies across the world, there are Gabriel Purse studies indicate that widespread detection of different viruses in cases as well as controls. So मग त्या स्ट्रेप्टोकोकस निमोनिया येतो, मायक्रोप्लाझ्मा निमोनिया येतो, मेटानिमो व्हायरस येतो, रायनो व्हायरस येतो, RSV येतो, पॅराफ्लुएन्झा 1-3-4 येतो, इन्फ्लुएन्झा A and B वेर इंडिपेंडेंट. सो त्याच्यातले काही सिग्निफिकंट असतात, काही नॉन सिग्निफिकंट असतात. सो कुठले सिग्निफिकंट धरायचे आणि कुठले नाही सिग्निफिकंट धरायचे याच्यासाठी हे स्टडीज झाले होते. सो त्याच्यामध्ये त्यांचं कोरिलेशन आहे की हे जर काही असतील, स्ट्रेप्टोकोकस निमोनिया आला, मायक्रोप्लाझ्मा निमोनिया आला, ह्युमन मेटानिमो व्हायरस आला, रायनो व्हायरस आला, रेस्पिरेटरी सिन्शियल व्हायरस आला, पॅराइन्फ्लुएन्झा व्हायरस आला, सो देर आर चान्सेस की इट मे कोरिलेट विथ द युअर लोअर रेस्पिरेटरी ट्रॅक इन्फेक्शन. ओके, सो बट इट इज अगेन there are so many limitations for upper respiratory tract biofire, so better not to send it in lower respiratory tract infections. So we have practice dilemma for etiological diagnosis. Viral hai, bacterial hai, mixed pneumonias hai. So does our infection markers help us in differentiating viral and bacterial pneumonias? CBC, CRP, procalcitonin. How many of you do procalcitonin? So we will discuss in ICU setup whether procalcitonin is really needed or not in that section. Radiological clinical, तो एक्सरे वरती लोबार आहे, लोबार निमोनिया आहे, एम्पायमा आहे, निमॅटोसिल्स आहे, रेटिक्युलर पॅटर्न आहे. विल दॅट हेल्प अस टू डिफरन्शिएट बिटवीन व्हायरल अँड बॅक्टेरियल निमोनिया? सो दॅट विल डेफिनेटली हेल्प अस. सो रिलेवन्स ऑफ रेस्पिरेटरी PCR, pathogens or bystander, again that you have to interpret wisely, and antibiotic stewardship viral. So हे सगळे प्रॅक्टिस डायलेमाज आहेत. सो व्हॉट वी हॅव टू डू? सिव्हिअरिटी ऑफ इलनेस डज नॉट इंडिकेट इटिओलॉजी. म्हणजे पेशंट सिरियस असेल तर तो व्हायरल आहे का बॅक्टेरियल आपण डिफरन्शिएट नाही करू शकत. स्पेसिफिक रेडिओलॉजिकल अपीअरन्स विल बी हेल्पफुल. ॲज वी डिस्कस्ड, इफ इन एक्सरे देअर इज लोबार निमोनिया, एम्पायमा इज देअर, निमॅटोसिल इज देअर, रेटिक्युलर पॅटर्न इज देअर, देन डेफिनेटली वी कॅन थिंक ऑफ मोर बॅक्टेरियल ओरिजिन. इन्फेक्शियस मार्कर्स आर नॉट हेल्पफुल. CRP पॉझिटिव्ह आलं तर ते आपल्याला डिफरन्शिएट करायला हेल्प नाही करणार की ते बॅक्टेरियल का व्हायरल आहे. Positive bacterial cultures, the bacteremic pneumonia and you have sent bacterial blood culture in severe pneumonia, that may help you. Community acquired pneumonia protocol remains very relevant, but clinical discretion is important. So as sir told की community acquired pneumonia treat करण्यासाठी तुम्हाला इन्व्हेस्टिगेशन करायची गरजच नाही आहे. तुम्ही clinically जा and you start treating. So while many viruses, especially adenoviruses can overlap bacterial pneumonia, so काही सर्टन व्हायरसेसमध्ये ॲडिनोव्हायरस कॅन मिमिक बॅक्टेरियल निमोनिया. अशा सिच्युएशनमध्ये देन PCR डुईंग विल बी हेल्पफुल फॉर यू. असे पेशंट्स असतात की ज्याच्यामध्ये CRP, ॲडिनो इज व्हेरी नटोरियस व्हायरस टू मिमिक ऑल डिफरंट इन्फेक्शन. सो ॲडिनोव्हायरस हा बॅक्टेरियल इन्फेक्शनसारखा मिमिक करतो कारण त्याच्यामध्ये CRP पण व्हेरी हाय. वी कॅन सी CRP इन द रेंज ऑफ 100-200 इन ॲडिनोव्हायरस इन्फेक्शन ऑल्सो. सो इन दोज सिच्युएशन्स द PCR विल बी हेल्पफुल to differentiate. Okay. Yeah. So the adenovirus is very notorious to mimic bacterial pneumonias. So in this child, fever persisted, tachypnea increased with mild distress, repeat X-ray suggestive of mild diffusion. What next test we will do? If the mild diffusion is there, पुढची टेस्ट आपण काय करणार? Ultrasound. Very good. So for pleural fluid detection, which modalities of choice? Ultrasound, CT test or MRI test? Ultrasound, easily available, easily done. So USG chest, learn bedside evaluation and make SOPs. आपल्याकडे नाही ह्याच्यामुळे अवेलेबल होत की आपल्याला बेडसाईड करायला, कारण त्याच्यासाठी बरेच स्ट्रिंजंट रूल्स आहेत. बट इन अदर कंट्रीज दे हॅव पॉकेट USGs. सो तिथल्या तिथे करतात, कॅज्युअल्टीमध्येच करतात. असं ते तिथंच बघतात फ्युजन आहे का नाही आहे का. सो आपल्याकडे थोडे स्ट्रिंजंट आहे. बट USG चेस्ट इज व्हेरी युजफुल. रिपीटिंग चेस्ट एक्सरे विल इट बी युजफुल in treatment of pneumonias? Progression है देखने के लिए. Yeah, okay. So non-responders, if USG shows no effusion, pneumonia mimics and no need, पण resolution झाले की नाही बघण्याची गरज नाही आहे. Okay. CT chest. So it is seldom required. Non-resolving pneumonias असतील, mediastinal lymph nodes or other differential diagnosis simulating pneumonias असतील, तर मग अशा कंडिशनमध्ये आपण CT chest करू शकतो. Pleural fluid analysis. How many times pleural fluid analysis is helpful? Gram stain, highly useful in empyema, cytology, lymphocytosis versus polymorphs, malignant cells if they are seen, it will be useful. Biochemistry is useful. ADA, LDH आपण करतो. So we don't do, okay? Because ADA they say ki they tuberculosis मध्ये positive असतं, पण see there are so many conditions like empyema, severe pneumonias, other autoimmune conditions where ADA can be high, so it is not useful. Culture, yes, culture is useful. Of course, AFB, gene expert, TB culture and LPA. Though the sensitivity is very low for gene expert, acid fast bacilli and pleural fluid, but still if you get it, you have definitive diagnosis, so it is done. Yes, that's what I'm saying. The sensitivity is very low. That's what I'm saying. Pleural fluid, the sensitivity is very low. But if you get the diagnosis, if you can clinch the diagnosis, then it is very good. So, because whether to start treatment or not, it will give. So you have to send, but sensitivity is very low. So we did the pleural tap under USG guidance. Only 20 ml of fluid could be aspirated. Thin turbid fluid was there. Proteins were 4.35 grams. Total WBC count was 8,000, lymphocyte 80%, gram stain, no organism was seen, ZN stain, AFB stain negative, ADA was not done, bacterial culture sent, result is available, no MTB detected, AFB culture is sent. So what can we interpret on this pleural fluid? Protein is more. Okay. Yeah, okay. Exudative. So एवढंच कळतं की exudative. बाकी काय आपल्याला फार कळत नाही याच्यामधनं. Okay. 72 hours later, fever persisted, tachypnea, intermittent distress is there. And because the child is worsening, cloxacillin was omitted and linezolid was added. Then repeat USG was done, multiloculated empyema, biggest sac was 150 ml, so they tried to drain it by putting USG guided ICD, पण 10 ml त्याच्यामधनं आलं, त्याच्यामध्ये काही मायक्रोब्स नाही मिळाले, लिम्फोसायटिकच होतं ते फ्लुइड, ICD रिचेक केली, पोझिशन कन्फर्म केली, मग काय करायचं, सो ते ट्राय टू इंजेक्ट युरोकायनेज, पण ते पण फार इंजेक्ट नाही करता आलं, 10 mlच पुश करता आलं आणि yeah, so what next? So in these such scenarios, CT chest will be helpful. कारण जर आपल्याला pediatric सर्जरीला रेफरन्स द्यायचा तर ते पहिले म्हणतात CT chest करा मग रेफरन्स द्या. Okay, so should we get CT chest in all cases of empyema? So CT of chest is required in very small proportion of children with empyema effusion, can show extent of fluid loculations and septi, can detect underlying lung abnormality, can find necrotic lymph nodes suggestive of tuberculosis, can show thickness of pleura, important for VATS and decortication surgery. Okay, so CT chest is required only in very few % of patients with empyema, so use it wisely because it has got very large radiation exposure. CT chest केला, cavity दिसते, right lung, lower lobe lung, इकडे कॅव्हिटी विथ लंग प्रोजेक्शन दिसते, हायपोडेन्स लिजन्स हिपॅटिक सर्फेसवरती, फायब्रोॲटलेक्टिक लिजन्स लेफ्ट लंग लोअर झोनला आहेत. सो ब्लड कल्चर नो ग्रोथ, प्लुरल फ्लुइड कल्चर नो ग्रोथ, PPD निगेटिव्ह, गॅस्ट्रिक ॲस्पिरेट प्लुरल फ्लुइड AFB जीन एक्सपर्ट सगळं पाठवलं निगेटिव्ह, ब्रॉन्कोस्कोपी रिफ्यूज बाय पॅरेंट्स बिकॉज अल्टिमेटली मग ते ब्रॉन्कोलर लावाज करूनच आपल्याला घ्यायला पाहिजे, तो पॅरेंट्स रिफ्यूज केलं. Then 3 weeks of illness, non-resolving pneumonia, whether this is TB or not. No sir, non-necrotic, necrotic lymph nodes nahi disle aplyala. So as there was no evidence for TB, so this is clinical acumen. Okay, now the diagnosis of TB, now the new guideline says unless and until you have got microbiological diagnosis, do not start. There is no role of empirical AKT in tuberculosis. आधी खूप असायचं की नाही रिझॉल्व होते ह्याच्यामध्ये दिसतं, सो स्टार्ट AKT. सो देर इज नो रोल ऑफ empirical AKT. You have to diagnose, you will have to have microbiological diagnosis. There is certain entity in recent guidelines that clinically diagnose tuberculosis. In those situations you can, but there you need to have your clinical acumen. And this pediatrician decided, as there was no evidence of TB, he continued on linezolid for 4 weeks and patient gradually improved, lungs recovered 8 weeks later, chest X-ray was normal. So okay?
Yes. Yes.
Yes sir, yes sir.
Yeah.
You are using 4 weeks. How will you differentiate with tuberculosis or
this single drug, linezolid फक्त. So that's what that is our clinical acumen. आपण TB ट्रीटमेंट नाही चालू की आपण लिनेझोलिडवर कंटिन्यू केलं आणि हिट कंटिन्यू. ओके. अल्टरनेटिव्ह. सो लिनेझोलिड वापरायचंच नाही असं नाही. आपण हे म्हणू दिस इज नॉट पार्ट ऑफ दिस अँटीबायोटिक. दिस इज नॉट अँटीबायोटिक स्टीवर्डशिप. सो लेट नॉट गो इन टू दॅट बिकॉज वी विल डायवर्ट फ्रॉम. दिस इज डायग्नोस्टिक स्टीवर्डशिप. या आय नो युअर पॉईंट इज व्हॅलिड. बट सी लिनेझोलिड वापरायचंच नाही असंही नाही. बिकॉज त्या पेशंटसाठी ते महत्त्वाचं आहे ना. यू नो लिनेझोलिड वाचवून ठेवायचं कारण ते अँटी टीबी ड्रग आहे, वापरायचं नाही वापरायचं नाही. पण त्या पेशंटला ते गरजेचं आहे. सो यूज इट वाईसली. ओके. दॅट्स द आन्सर. So case 2, 3 years 7 month boy, fever for 5 to 6 days, 100 to intermittent day 1 to day 4, fever on day 5 6 increase 100 to 103, cough since 3 days, cough increase with pain in abdomen, admitted on day 6. तो 6 दिवसाचा फीवर आहे. सुरुवातीला 100 मग 100 to 103 झाला. 3 दिवसापासून कफ पण आहे आणि कफ इन्क्रीज्ड विथ पेन इन ॲबडोमेन. जनरली सिक आहे, ड्राउझी, फिब्राईल, टॅकिपनिक विथ डिस्ट्रेस, chest, bronchial breathing right side with bilateral clefts, pulse, tachycardia, blood pressure 90/65, saturation 88, decreased urine output. So this is the clinical scenario and treatment started in triage. What treatment started? Because the child was tachycardic, tachypneic, poor oral intake, IV fluid bolus was given, IV fluid started, and because the child was having low saturation, BiPAP was started with vancomycin verapamil. Okay, that's what the treatment what was started actually. Now investigation HB is 8 gram, total WBC count 1300, neutro 60, lympho 40, severe leukopenia was there. CRP was so high, 453.55 milligram. Blood culture was sent, result is awaited, X-ray test is done, which you can see. USG test showed minimum non-tappable fluid. So what may be the possibility? So very high CRP, leukopenia, community acquired pneumonia. So what are the different causes of bacterial pneumonia? Staphylococcus, pneumococcus, streptococcus, pyogenes. But severe leukopenia indicates fulminant sepsis, and Staph aureus, MSSA or MRSA PVL. What is PVL? Pontine valentine leukocidin. It is a cytotoxin produced by Staphylococcus aureus, causes leukocyte destruction and tissue necrosis. That's why low leukocyte count was there. It may be associated with classic severity factors such as ARDS, the need for mechanical ventilation, inotrope support, erythroderma, airway bleeding, and poor prognosis. Okay. So in this scenario, treatment should be started immediately, and they have started with IV fluids with bolus, BiPAP, Vanco, Mero, and they added suspecting staph, MRSA, clindamycin to stop the toxin production also. But patient worsened, put on ventilator, USG chest showed moderate pleural effusion on the right side, 200 ml of stroke-colored fluid was aspirated. This is the color of the fluid. And the pleural fluid examination was done, gram stain, no bacteria was seen, proteins 3.8 gram. Pleural fluid serum protein level 0.77, more than 0.5 suggestive of exudate. So exudative was the glucose 52, LDH 4550, cytology 750 cells, 90% neutrophils, culture no growth. But child is stable on ventilator, off inotropes, fever settling, almost febrile, but child is on Vanco, Mero and Clinda. हे 3 antibiotics चालू आहेत. So dilemma is that which antibiotic continue, to which antibiotic child has responded. The blood culture is sterile, pleural culture is sterile, de-escalation is not possible. How to identify the pathogen? The patient, yeah, that's okay. Pleural fluid? Culture, pleural fluid culture, no growth, madam. Bile refused by patient. Yeah, okay, mini bile, yeah, the point is there. Okay, bile मध्ये पण नाही आला आपल्याला काही. बाल मध्ये पण नाही आलं काही. प्लुरल फ्लुइड कल्चरला नाही आलं, ब्लड कल्चरला नाही आलं. So this is the real case scenario. What they did, they sent, this was the case from north side, I think Ram Manohar Lohria hospital, RML hospital case होते. They sent pleural fluid for multiplex PCR. Okay, multiplex PCR is not developed for pleural fluid, पण they did this जुगाड. Pleural fluid multiplex PCR is actually for respiratory as well as bronchoalveolar lavage आणि तिथून जे secretions घेतो त्याच्यासाठी आहे. But they send it on pneumonia panel on pleural fluid, and what they found, they detected Streptococcus pneumoniae. So this was jugaad they done. This is not ideal recommendation, but sometimes. त्याच्यात नाही आलंय सर, नाही आलंय. आय नो कशातच काही नाही आलं. येस, कशातच काही नाही आलं म्हणून त्यांनी हे पाठवलं.
Why we want to escalate? Continue that antibiotic. This is you are done. It's jugaad.
मेरो वँको क्लिंडा सर किती दिवस देणार? सो दॅट्स वाय आय एम टाक वी आर हिअर फॉर स्टीवर्डशिप नो. तर मग असंच करायचं तर मग स्टीवर्डशिप कशाला करायची? मग सगळंच देऊ ना आपण त्याला. मग देऊ 21 दिवस सगळं देऊ त्याला, आपण 21 दिवस 3 आठवडे देऊ त्याला, इथेच ॲडमिट करू. सो वी आर हिअर फॉर स्टीवर्डशिप. सो दिस कॅन बी डन. सो द थिंग इज दॅट वी कॅन समटाईम्स सेंड न्यूमोनिया पॅनल. सो मल्टिप्लेक्स PCR अशी कधीतरी हेल्पफुल ठरू शकते. सो स्ट्रेप्टोकोकस न्यूमोनिया वॉज डिटेक्टेड. द चाइल्ड वॉज डिस्केलेटेड टू सेफ्ट्रियाक्झोन. 3 हाय अँटीबायोटिक्सपासून त्याला सेफ्ट्रियाक्झोनला आणलं आणि he was extubated on date, counts platelet improved, discharged on date on amoxicillin. So he real world case hai, real world case hai. So here the diagnostic stewardship helps us. Learning point, CBC CRP just corroborate you, cannot help you to differentiate. Blood culture blood culture is must in febrile suspected bacterial pneumonias. PCR, nasopharyngeal PCR panels, deceptive, limited role, judicious interpretation, expensive. They can show trend of circulating viruses in community. ह्याच्यामध्ये 2 viruses पॉझिटिव्ह होते. सो त्याचं काय करणार? त्याचं काहीच केलं नाही आपण. सो बाल मिनिबाल more relevant specific for LRT panels can be done off label on pleural fluids and exudate. Off label, it is not recommended for, but people are doing this off label. Specific respiratory PCR like COVID, influenza more relevant in outbreak situation and cost saving. X-ray chest more important for LRT, especially in office hospital practice. USG for effusion needs to be encouraged for diagnosis and monitoring. CT chest selected indication for non-resolving pneumonias, mediastinal lymph nodes, other DDs simulating pneumonias. Pleural fluid analysis of immense importance for bacterial fungal culture. It is reliable. TB detection by gene expert LPA culture is suboptimal because very low sensitivity, but still you have to do it. Thank you. Thank you very much.
Sir, so are you recommending pleural fluid biofire in difficult situations? Are you recommending this?
When the
Or suppose had this organism in something else, E. coli or Klebsiella?
so this is when you are pushed to boundary. काहीच नाही आता काय करायचं अशा वेळी त्यांनी ती केली होती. सो द मेसेज इज दॅट डोंट वेट फॉर टेस्ट. आपल्याला काही मिळत नाही आहे म्हणून आपण तेच अँटीबायोटिक्स चालू ठेवले असं नाही. सो व्हॉट दे डीड सम जुगाड. बट सी द इम्पॉर्टंट थिंग इज की वेरो मँको क्लिंडावरनं अमॉक्सिसिलिनला आले. सो इट हॅज हेल्प देम.
Not required.
Yeah. So this is real world scenario. This is not my case. But what I'm saying that so sometimes when we go away from routine our diagnosis. Yeah, I know. So, yeah. So the point is, this is the jugaad where they did, but this is not the standard recommendation of doing PCR panel on pleural fluid.
Thank you, sir. Now we will have inauguration ceremony and felicitations of the speakers. So I request our Dr. Atul sir to come up, Vice President, National West Zone. I request today's MMC observer, Dr. Patankar madam. I request Dr. Pramod Kulkarni sir, Dr. Keyur sir, Sucheta madam, Aishwarya madam to come up for the lamp lighting. Pramod sir. Pramod.
बायका काहीतरी 5 द्या आलं त्याला काय होतं त्याला एक थायमिनची गोळी चालू होती ती कमी गेली की त्रास होते जन्मल्यापासून थायमिनची गोळी मला ते घरी गेल्यानंतर त्या दिवशी माझ्या मास्टरपर्यंत लेक्चर होतं मला डोक्यात किडा वगैरे
Please come. Please come. Sucheta madam.
हे इन्सुलिन कधी
पाटणकर मॅडम.
त्यांनी मला म्हणलं हे करून बघू. डायबिटिक प्रोफेशनल म्हणलं ते क्वेरी काढून म्हणलं त्यांनी टाकून ते पाठवून घेतलं त्याने बरोबर बसतंय. सेन्सिटिव्ह न्यूरल डिफनेस आहे, त्याला 80% डिफनेस आहे. तर आवीला म्हणलं कागद लिहून ठेव. ते पेशंट सगळं सांगितलं, पेशंट चांगला झाला, आता पेज चांगलं आहे. ते म्हणते ते सबक्यूट इंजेक्शन रोज घाला लागते का? आम्ही जातो बँगलोर. आता काय
हां तुम्ही पुढचं लावा दोघं लावा ना पुढचं.
नाही पोस्टर करा.
अरे ते फोटो लाव ना.
त्याला 2 मुलांचे ट्विन्स आहेत. दोघंही त्यांचे
सरांचा अगोदर लावू दे का आता फेल स्टेशन करूया मग त्यांचं लावून मग तुम्ही शेवटी. Now I request Dr. Atul sir to felicitate Dr. Pramod Kulkarni sir.
सबक्यूट इंजेक्शन रोज घेतात. काय पैसा त्याच्यात ते सब इंटरेस्ट लावून थोडं त्यात प्रॉब्लेम येतात ना. अरे ते हे बंद करते प्रोजेक्टर समोर जागा घे काहीतरी. कुठे प्रोजेक्टर
अलीकडे या sir. इकडे तोंडावर येतं थोडं अलीकडे. मॅडम इकडे ऐश्वर्या मॅडम.
प्रोजेक्टर बंद कर.
हां इकडे हां नाही ते I request Dr. Madam, just wait for few minutes. Madam, please come, please. I request Dr. Sate sir to felicitate Dr. Keyur sir. I request Dr. Vaidya sir to felicitate Dr. Suchita ma'am.
कोण अण्णा
I request Dr. Patankar madam to felicitate Dr. Aishwarya ma'am. Now I request Dr. Kumbhare sir to felicitate our MMC observer Dr. Patankar madam. Thank you, madam. Thank you. I thank all the speakers. Now we would like to play a message from our National President, Dr. G.V. Basavaraja, sir.
Namaskar. Greetings from Indian Academy of Pediatrics of the above 45,000 members. Let me congratulate our IIT Solapur branch, led by Dr. Anna Saab Mumbai, Secretary Dr. Gaya Mansudan Gaikwad, and Treasurer Dr. Sandeep for organizing an excellent diagnostic stewardship module. Diagnostic stewardship module is one of the flagship program of Indian Academy of Pediatrics, which has been prepared by none other than Dr. Vijay Yavle, Dr. Suhas Prabhu, along with the national coordinator Dr. Sanjay Gorpade, who has been taking care of this module. And this is in a module which has been addressing all the diagnostic issues which has been related to the day-to-day clinical problem, along with the latest things like a microbiological thing. And the Maharashtra IAP National Executive Board member Dr. Amul Pawar, Dr. Sanjeev Joshi, Dr. Renu Boralkar, Dr. Vinayak Patki, Dr. Bela Verma, Dr. Jitendra Gavane, who has been instrumental in bringing this module under the guidance of a great stalwarts of our West Zone Vice President Dr. Atul Kulkarni, who has been very instrumental in coordinating with all the things. And of course today's faculty, who has been in benchmark faculties in the Indian Academy of Pediatrics, like Dr. Aishwarya Kulkarni, Dr. Pramod Kulkarni, Dr. Mahajan, Dr. Sucheta. Their deliberation is going to be very, very useful. And of course our action plan team, which has been coordinating with all the branches, led by Dr. Gnanamurthy, our joint action plan coordinator, Dr. Amul Pawar, our another Joint Action Plan Coordinator, Dr. Nandish B. Under the guidance of our Dynamic Secretary, Professor Yogesh Parikh, Dr. Atanu Bhadra, and of course, Atul Kulkarni, who has been coordinating with Action Plan team as well as our office also, their interaction which is made this module to happen. Best wishes for the today's program. Looking forward to conduct a more program at this under all the IAP Solapur, which is the most active. Best wishes for this.
Thank you, sir. Now I request Dr. Atul sir, backbone of our all the programs, to few say words.
Thank you, Anna. Good afternoon, everyone. From Central IIP, as a Vice President, I welcome you all for today's Diagnostic Stewardship module. I welcome all the faculties down in the field of ID, Dr. Pramod Kulkarni. We always enjoy his talk and his clear concepts and crisp messages. One round of applause for Pramod. Yes, yeah. Also, today we have Keyur, Dr. Sucheta and Dr. Aishwarya. They are adding to the this module. They are doing an excellent job. This module is really a very nice module which is prepared basically for practitioners and what to do and what not to do. RRR, you know, RRR is a Telugu film, very popular Telugu film. RRR, and here RRR is right patient, right time, right test and right time. So this module is again becoming very popular like the RRR film. I like to congratulate our SAP President, Dr. Anna Saheb Lokande. He is doing an extraordinary job. What now the people are getting exhausted because every month we are having 3-4 programs, and all the programs are very good programs. He is doing social activity also, going in all the presidential action plan what is been given. He is doing all the programs. He is doing in the social and also academic programs. So I congratulate Anna Sahib, then Madhusudan, Vidyanand and Sandeep and entire team. So thank you and happy learning. Thank you. Thank you very much.
I thank you for sir's message and blessings given by all the Solapur Academy of Pediatrics members. Without you and your support, it is very difficult to continue all the activities. So I always seek your support. Now I request Dr. Atul sir to felicitate our sponsor academic grant. Please come up. A representative from Bharat Biotech. I request Dr. Atul sir to felicitate. Representative from the Bharat Biotech. I thanks once again to the Bharat Biotech for sponsoring the academic grant. Thank you very much. Thank you, sir. We will proceed with Dr. Pramod Kulkarni sir's lecture.
So apart from sincere thanks to Bharat Biotech, we address few of their products and vaccine relevant to this diagnostic stewardship as well. So as we have seen infection prevention and control, we have got infection prevention control as one of the important pillar of infection management and control. So looking at it, how does vaccination help? Reduction in infective syndromes, that is a reduction in diagnostic, reduction in antimicrobial usage, reduction in secondary bacterial infection of a viral infection, decrease in laboratory use and antimicrobials. So all the way this is useful. So what are the new vaccines? We have got many new vaccines. All of us are updated about it. Today we are going to touch the JE vaccine, rotavirus vaccine and typhoid conjugate vaccine. So let's go ahead. Typhoid vaccine, you know very well, gold standard is blood culture, not available or not done. Less than 3% of the total febrile suspected typhoid episodes are culture proven. So for every case, true case or culture positive case, there are about 3 to 25 probable cases which are not picked up. And is an invasive bacterial disease and involves young age too. We have to keep in mind less than 2 years form about 20% of the total patients of typhoid fever. Then we know very well how typhoid was initially diagnosed and the antimicrobials were introduced, and within 10 years of introduction of effective antibiotic, the resistance was reported, and after 2 decades, 2 to 3 decades, total resistance was reported. So non-susceptibility was reported and the antibiotic was useless after 20 to 25 years. And recently we have come to the era of uselessness of quinolones in typhoid. Now we are left with ceftriaxone. Maybe another year or so, it will also be left out of our hands. So rising antimicrobial resistance, drug-sensitive typhoid to MDR typhoid, now XDR typhoid. Good to diagnosis, better to treat well in time, but best is prevented by effective vaccine with wash technique, which becomes so important. So water, sanitation and hygiene. So typhoid vaccine, we know well, during the evolution initially there were TAB vaccine which had very high reactogenicity, though phased out. Then we had TY21A oral vaccine, had its own limitation but efficacy of about 50 to 60%. Then we had the polysaccharide typhoid vaccine, again had a similar efficacy of 50 to 60% but was used a lot. And then we had this conjugate vaccine over last few years, which is really very good, very useful, and there are different brands available with different conjugate protein use. So TT in sub, CR in sub and DT in sub. So depending on this, we have a lot of products available in the market for the typhoid vaccine and different basis of their preparation and chemical preparation of it. So looking at the seroconversions and efficacy, we know human challenge studies, which are the final proof for efficacy. Efficacy is about 87%, definitely effective. And the geometric mean titer or concentrations were above protective level of 4.3 microgram. Definitely, and zero efficacy was 85%. So this is really a good vaccine, very effective vaccine. WHO recommended it and is being used in many of countries beyond India effectively with proven efficacy and effectiveness. Nepal, Malawi, the efficacy has been established. Bangladesh, Pakistan, Zimbabwe, everything, they have used it and it is established. In Navi Mumbai in India for the first time under leadership of Dr. Yevle, it was used by the municipal corporation in 2018 to 20, and again the efficacy and effectiveness was proven beyond any doubt. And with single dose and booster dose, the controversy going on, there is reasonable persistence of antibodies, protective antibodies, up to 5 to 7 years after first dose. Thereafter also, though they drop, there is residual protection, definite protection. The question is yet unanswered, and after few years will be coming out recommendation for a booster. For time being, the IAP, ACVIP recommendation stands as a single dose of typhoid conjugate vaccine 6 months earliest, up to 1 year can be given, and that is the recommendation. About booster will be waiting for the further recommendation in next coming years. So there is no doubt about efficacy of single dose as well as booster further extends the protection for a few more years, and maybe that will come as a standard recommendation. So again the same thing. So right now the avidity with this is very high. Again the avidity says that the boosting is going to be more effective, or the natural exposure is going to be more effective. So the other cell mediated memory immunity and all those things are really very effective. We are looking at only the antibody levels, and there is other memory, cellular memory also is going to help. So let us wait for the second dose as a recommendation. Looking at the second vaccine, JEV, we are using it. You know very well, last few years, almost all India states have been declared as JE endemic. 368 districts, 22 states, and Maharashtra as well as Solapur and Pune are also under that. And the vaccine is being administered in the government setup as well as in private by all of us. So JE, we know there is a burden of JE definitely in the monsoon season because of the mosquito pest during the monsoon season. So apart from the common dengue and chikungunya, malaria is gone, but JE is definitely a preventable serious disease, acute encephalitis syndrome, and it definitely contributes towards the burden of acute encephalitis syndrome. So this is a preventable disease, and you know the life cycle of JE, it is with the vertebrate host, the wading birds, the vertebrate host, and man as the what they call is no further way, end point of the cycle, but there is high morbidity and mortality associated with that. So, JE virus, there is enzootic, pig control, mosquito control, vaccination. These are the three arms of prevention, and vaccination definitely the most effective one, other two beyond our control. Okay, methodology, you know, it is not an outbreak response vaccine. It's a regular universal vaccine recommended nowadays for children between the age 1 to 15 years and high-risk travelers visiting the high-risk areas. Does not induce herd immunity. That is the only problem with this vaccine. So JE vaccine again evolved. Initially there were mouse-borne vaccine which were highly reactogenic, and now we have got the next generation vaccine, very effective and quite safe one, and we have got two products in the private as well as one government product which is not available. The Chinese make is not available in private, but these three are being used. All three are comparable, but there is little difference in the protection as well as the dosing schedule as well. Okay. So Genvac, GIV, these are the two. Genvac is polar strain and GIV is SA-1414-2 strain derived one. These two are available in private, as well as this CD Gvax is available in government only. Recombinant is yet to come. So comparing these two, GIV and Genvac, you know, they are almost comparable. The age is 1 year minimum age. 2 doses for GIV have been recommended. Genvac, the company recommends 1 dose, but the IAP, ACVIP says it's better to give 2 doses only, not to go for single dose, even if it is proven to be effective, equally effective. Catch-up may be given. Again, the answers are not clear. Need for boosters yet to be answered. So, interchangeability, there is no doubt that you can interchange. The basic principle of vaccinology, as far as possible, stick to the same brand for antigenic advantage, having the same antigen and the same memory being boosted and protection being superior. But depending on, recently there was non-availability of Genvac, we had to use GIV as well. And in this scenario, again about the typhoid vaccines and PCV as well, ideally what is recommended is better not replace the original brand. If it is not available, then and then you can definitely change. Little reduction in efficacy, but it is definitely proven to be effective and is being recommended if there is no alternative. Same is with GIV and Genvac, and there are studies saying first Genvac, second GIV, first GIV, second Genvac, and all those combinations, they are effective. There is no doubt about that. Seroconversion, seroprotection, all are reliable. Genvac is a reliable, so JE vaccine, Genvac is a reliable vaccine. We are using it, and we have to use it in view of the high morbidity and mortality of JE disease as such. Rotavirus vaccine, we are using it over decades now. We know very well the pioneer vaccine from India by Bharat Biotech, launched by our honorable Prime Minister Mr. Modi, and is world over now, is proven efficacy. Our own indigenous brand, very effective. Again, cross protection is there. There is no problem. It's live oral, now available with lower dose as well. And again here the same principle, the interchangeability is there. Better to stick the first one. If it is not available, go for the second one. There is no doubt about efficacy of all the rotavirus vaccines available, and let us go with the indigenous brand, efficacy and effectiveness of which has been proven beyond doubt. Okay, so human bovine monovalent, only P4 is bovine, and there is there is a definite cross protection. A specific host we have seen, prematures and all these strains and the antigenicity all are comparable about all the vaccines, but this particular vaccine is our indigenous one and it is highly effective. There is robust immune response, please go ahead with that. Okay, and it is being established all over the world, the efficacy is beyond doubt. Okay, so efficacy as we know it is roughly around 50 to 60%, mainly in view of burden of the disease, prevention of infection, and not only that, prevention of symptomatic infection and serious infection in form of requiring hospitalization and rehydration. That is the thing which is definitely protected, and incidence of infection is also decreased. We perceive in our practice the diarrheal diseases are going down day by day, especially the hospitalized cases. And a lot of the credit goes to the effective rotavirus vaccine which is available. So we have got in half dose also, low volume for administration convenience as well. And the risk of intersusception, it is now said that it is practically no more than natural incidence. That's all about 3 effective vaccines, and thank you very much Bharat Biotech for giving us these 3 brands. We are with that. Thank you very much.
To proceed further, ICU infection, I request Dr. K. sir.
So for going preventive mode to combat mode in ICU infection. Okay. So in ICU infections, there are so many challenges, so many opportunities. We need to have appropriate tests to reduce the cost and adverse outcomes. We have unconfirmed infections. We have so many empirical antibiotics, and which we need stewardship to help to de-escalate and stop antibiotics. We have so many resistant infections. We need to identify them quickly for early appropriate therapy. We have multiple team members and specialized care precautions to avoid sampling errors, redundant tests. So we have so many opportunities and challenges in treating patient in ICU. Now 3 questions to ask in fever in ICU. Are there signs and symptoms of an infectious process? So whether this is really fever due to infection or not. For example, fever is there, dysuria is there, suprapubic pain is there, then definitely there are chances of UTI. Okay, in the child with urinary catheter infection, so it can be COTI. Then what is the best diagnostic test to evaluate? For example, in urine infection, you have to do urinalysis in urine culture. And third question, how should a sample collected? If there is COTI, that is catheter associated UTI, then we have to insert new catheter in place and fresh sample should be collected. So these 3 questions are related for any fever which is appearing in ICU. Are there signs and symptoms of infectious process? What is the best diagnostic test to evaluate? And how should sample be collected? Now case 1, we straight away go into the cases. 12-year-old boy weighing 60 kg, severe right lower quadrant abdominal pain, vomiting and fever for 2 days. Mother noticed a transient redness over extremities earlier in the day. No recent antibiotic exposure, in fluid refractory shock, diffuse abdominal tenderness is there. So this is the child, 12-year obese child, 60 kg and in shock. So lab is there, HB is 11.5, total count 2100. Differential polymorphic count, platelet count is borderline low, CRP is 250, lactate is 4, so definitely in shock. So bedside USG abdomen was done, it was normal. Remember, he is having right lower quadrant abdominal pain severe. So chest X-ray is normal, then urine routine 3 to 4 pustules, no RBCs protein, so no UTI also. So what differential diagnosis comes in mind, what test to order?
Dengue fever, I want to do NS1.
Good sir. Dengue fever. Then will you do procalcitonin? So how many times we use procalcitonin? Okay. So we used to say कि CRP आपला मिथुन चक्रवर्ती procalcitonin अमिताभ बच्चन. म्हणजे both have good value. Okay. Procalcitonin is very costly test, so need not be done because you have got CRP. If you want to evaluate at all inflammatory markers, CRP has a good corroborative value also. So procalcitonin will not add any additional information. There is role of procalcitonin in certain situations. Procalcitonin is if you are having a child in ICU and he spikes fever and you need to differentiate whether it is bacterial or viral. In only those scenarios, because procalcitonin rises very early than CRP. Here you can have your role of procalcitonin only. Okay, otherwise procalcitonin will not help you much. Tropicals.
Why not toxic shock syndrome?
Pardon?
Why not toxic shock syndrome can come in?
Yeah, it can be. So this is the patient who had come in COVID era. Yeah. So we are discussing different. If you want to ask, this child came in COVID era. Okay, COVID era, post-COVID. COVID मध्ये आपण असे पेशंट्स फार पाहायचो. Okay, so keep in that way. So what investigations they send tropical screen. Tropical screen मध्ये dengue NS1 IgM पाठवायचं का? As sir said, yes, we should send. Blood cultures पाठवायचे का? This is very good culture to do blood culture तर पाठवायचं because this child came in COVID era, they were suspecting MISC also. So they did the pro-BNP D-dimer, sorry. So they did MISC workup also. And they did CT abdomen also for surgical opinion CT abdomen because he is having right lower quadrant abdominal severe pain and no USG didn't detected anything. Okay, so procalcitonin no, but other tests can be done. Blood cultures, it is good culture to take cultures. Now, whatever the sensitivity of blood cultures is given, it is whatever literature is there, it is based on 2 sets of blood culture. Okay. So perform for all fevers before starting or changing antibiotics. Blood culture is must. Optimum amount 2 to 3 sets are to be taken. Ideally minimum 2 sets. Because if you take 1 set, yield is 73%, with 2 sets 89.7%, 3 sets 98.3%, 99.8% with 4 sets of blood culture. So ideally if you want to send blood culture, please send in 2 sets. It may not be from different site, you can take it from same site also, but send at least 2 sets of blood culture. Clean puncture site with 2% alcohol, chlorhexidine, so proper cleaning should be there, okay, because to avoid the contamination. Automated cultures are better, but any culture better than no culture, because in periphery automated available nastil, but any culture is better, but automated culture are definitely better than the manual cultures. Early transport, store at room temperature for less than 2 hours. जर तुमचं ब्लड कल्चर युरिन कल्चर जर घेतलं आणि सॅम्पल जर आपल्याला पाठवता येत नसेल तर यू हॅव टू रेफ्रिजरेट इट. ओके, फॉर युरिन कल्चर रिमेंबर यू कॅन रेफ्रिजरेट इन कीप इन रेफ्रिजरेटर फॉर 4 hours मॅक्झिमम, नॉट मोर दॅन दॅट. सो युरिन कल्चर सॅम्पल घेतलं लॅब लगेच जाणार नसेल तर ते फ्रीजमध्ये ठेवा, पण ब्लड कल्चर घेतलं आणि लॅब लगेच जाणार नसेल तर ते रूम टेम्परेचरलाच ठेवा. दॅट शुड नॉट बी स्टोअर्ड इन फ्रीज. ओके, बट किती वेळ? मॅक्झिमम 2 hours, नॉट मोर दॅन दॅट. So what amount should be taken? Blood culture is a cornerstone in sepsis management. For small children, culture set 4 ml, aerobic 2 ml in aerobic. Total 6 ml ideally should be taken. For 12.8 to 36.3 kg, 10 ml. This is ideal. This is what all the sensitivity tests, जे आपण सगळ्या स्टडीज बघतो त्याच्यामध्ये सेन्सिटिव्हिटी आहे इतकी, पण आपल्याकडे ब्लड कल्चर येतच नाही पॉझिटिव्ह. सो वी से की आम्ही पाठवतो पण येतच नाही पॉझिटिव्ह. Why? Because we take very less volume. So the good volume should be taken. For 36.3 kg, the ideal recommended volume is 20 ml, 20 ml. They say you can take both aerobic and anaerobic also. पण मुलांमध्ये anaerobic infections फार rarely असतात. So if you have less volume, send aerobic. Aerobic is preferred than anaerobic. But if you have good volume, in older children you can send aerobic also, anaerobic also. Especially anaerobic culture should you always send in abdominal and necrotizing infections. But the amount of blood is very important if you want to have good positivity of your blood cultures. So in this child, because child was weighing 60 kg, they had sent 2 sets, 20 ml each. And they started on IV meropenem. Surgeon wants urgent CT abdomen because he had right lower quadrant pain for probable appendicitis with peritonitis, but patient is too sick to be shifted immediately. Echo was done. ECG showed sinus tachycardia. Then they did the other investigations because I said because this was in COVID era, तर मग त्यांनी NT, D-dimer, TROP-T वगैरे सगळं केलं. Mechanically this child went into ventilation. The child was mechanically ventilated on pressors and antibiotics, vancomycin, clindamycin added for probable toxic shock syndrome. सरांनी जसं म्हटलं सर. So they added vanco and clinda. Still not improving. Blood cultures flagged gram-negative organism at 12 hours. This is automated. This is the beauty of automated cultures. Automated cultures तुम्हाला 12 ते 24 तासात पण तुम्हाला ग्रोथ फ्लॅग करू शकतात. They can tell you whether organism नाही सांगू शकत, but they can tell you a gram negative, a gram positive, that you can come to know. Then CT abdomen reveal. Then the child, when child was stabilized, CT abdomen was done. It revealed retrocecal appendiceal collection. Operated emergently, appendicectomy was done and drainage of collection was done. So what sample should be sent from the theater? If any appendicectomy is done, तिथं आपण fluid घेतलं तर कुठलं काय पाठवायला पाहिजे? That fluid should be, which test? For which test?
Culture.
Okay. Yeah. So 1 to 10 ml of fluid inoculated directly into aerobic and anaerobic blood culture bottles. So it is recommendation. These are the standard recommendation. You can directly inoculate that sample into the bottles meant for blood culture. Lab तिथेच OT मध्येच तुम्ही ते घेऊन directly inoculate करू शकता. Because we are having intra-abdominal infection, we can send anaerobic. We should send anaerobic also. Okay. So in addition, as sir rightly said, 0.5 ml of fluid should be sent for gram stain and if indicated fungal cultures also. Gram stain आपण आता हल्ली विसरत चाललो, पण gram stain is also very important. So blood and pus cultures grew E. coli. And it is ESBL positive organism. Now what? So then the sensitivity pattern is there. Atrapenum there is, imipenum there is, meropenum is there. So now they escalated. आपण काय काय स्टार्ट केलं होतं सुरुवातीला? वँको, मेरो सगळं स्टार्ट केलं होतं. So culture grew E. coli and it is sensitive to atrapenum, meropenum. So they de-escalated atrapenum and did well. So the key message is blood cultures are the cornerstone in sepsis management. Imaging studies like CT abdomen are crucial add-on in diagnosing difficult and hidden infections. Before invasive procedures, it is important to make a plan and specify the sample required to the surgeon and interventional radiologist. The point message is that appropriate volume is very important for sending blood culture. 2 sets minimum पाठवायचे, age appropriate volume पाठवायचं. जर ते पाठवायला उशीर होत असेल तर 2 तास रूम टेम्परेचरला ठेवू शकता. युरिन कल्चर जर पाठवायचं असेल आणि ते उशीर होत असेल तर तुम्ही फ्रीजमध्ये 4 तास ठेवू शकता. आणि जर तुम्हाला इंट्राअब्डोमिनल इन्फेक्शन आणि नेक्रोटायझिंग इन्फेक्शन सस्पेक्टेड असेल तर एरोबिक प्लस एनोरोबिक पाठवायचा प्रयत्न करा. टेक गुड व्हॉल्यूम अँड सेंड बोथ. इफ व्हॉल्यूम नसेल मिळत तर सेंड ॲरोबिक, डोंट सेंड एनोरोबिक. पण गुड व्हॉल्यूम इज व्हेरी इम्पॉर्टंट फॉर पॉझिटिव्हिटी ऑफ युअर ब्लड कल्चर्स. Case 2.
Sir, can you elaborate on de-escalate to ertapenem?
So this is the real world case scenario. Ertapenem and meropenem same group of, but they found that ertapenem is much better than meropenem. हा डिस्कशन झाला होता की डिस्कलेशन कसं होऊ शकतं. बट मल्टिपल अँटीबायोटिक्स पासून ते एका अँटीबायोटिकला आले. मेरोपेनम आणि वँको चालू होतं ते एक अर्टापेनम. सो दॅट्स वाय दे कॉल्ड इट एज अ डिस्कलेशन. सो मेरोपेनम टू अर्टापेनम दे ऑल्सो दे कॉल्ड इट डिस्कलेशन.
Is it difference between the two, erta and mero?
Action wise yes, but again as I said we will not go into antibiotics कारण हे स्टीवर्डशिप आहे मग ते डायव्हर्ट होतं त्या गोष्टी. ओके, खूप मोठं मॉड्यूल राहिले. प्रीटर्म निओनेट्स केस 2 30 weeks 1.8 kg, Apgar 7/10 8/10, tachypnea at birth, no history of maternal fever, UTI, prolonged rupture of membranes, chorioamnionitis, respiratory rate 67, subcorsal retraction, saturation 90% on CPAP support. So what has received antenatal steroid, postnatal surfactant also. Blood culture 2 bottles sent by peripheral prick, started on ampicillin and amikacin. Why amica? We will come to that. So what you suspect in this? Preterm neonate, tachypnea, saturation low. So what is clinical diagnosis? Early onset sepsis. Okay. So what are the investigations required in managing patient with early onset sepsis? Do we need CBC? Do we need CRP? Do we need procalcitonin? Do we need urine routine? Do we need chest X-ray, blood culture, urine culture? So do you send all these tests in all patients of early onset sepsis? So tests, what can be done? CBC, CRP, PCT. Ata CRP and PCT, again this is the discussion, the PCT. So procalcitonin as we have discussed it is costly test. Not necessary to send it always. CRP and PCT has good corroboration, but only difference is PCT is early to rise, so it can give you early diagnosis than CRP, but it is very costly, so it is up to you. Blood cultures, definitely. Urine testing, do you send routinely urine testing in early onset sepsis?
Late onset we said, not early.
So not routinely. So CPC-CRP at 6 to 12 hours of birth, repeat at 18 to 12 to 24 hours of birth. Blood cultures definitely at baseline before antibiotics. Urine testing not routinely recommended. Chest X-ray, if any respiratory distress, definitely we will do. CSF analysis, strong clinical suspicion of sepsis, features of meningitis, culture positive and not improving as expected, we should go for CSF definitely. Do not delay and do not hesitate to do CSF examination in neonates. You have to do. And swabs on purulent size as clinically indicated. So consider stopping antibiotics at 36 to 48 hours if cultures are negative, initial suspicion not strong, 2 consecutive CRP are negative, reassuring, baby is improving. So आपलं एक hesitancy असते antibiotics stop करण्यासाठी. So you have to come over that hesitancy, and depending on our clinical acumen and laboratory parameters, we should have courage to stop antibiotics if all parameters are against sepsis. So this is the take-home message. Again, blood cultures volumes in newborn less than 1 kg, 2 ml aerobic, 1.1 to 2 kg, 2 ml, 2 plus 2 ml, don't sets पाठवायचे. So this we have discussed earlier. So appropriate amount of volume is very important if you want your culture to come positive. And anaerobic cultures, as we discussed previously, abdominal and necrotizing infections, you have to send anaerobic culture also. Again, early onset sepsis, assess presence of risk factors and clinical signs, start treatment based on assessment. CBC biomarkers do not determine need to start antibiotics. जर sepsis वाटत असेल आणि CBC CRP रिपोर्टची वाट येत बघण्यासारखा, we have to start. We should start. But yes, remember, you should stop also if the sepsis work is negative. Start करायचं, पण you have to be that vigilant that की sepsis work negative आहे, baby ठीक आहे, तर you should stop it. However, they are helpful to stop antibiotics when negative and suspicion of sepsis is low. So labs, now in this child we have HbO 14, total count 7,800, platelet, polymorph 74%, platelet count 2.8 lakh, CRP is 1.5, chest X-ray bilateral initial infiltrates. Blood culture on day 2 showed gram-positive cocaine 1 bottle, baby still on CPAP, no tachycardia, shock. What do you do? CRP is negative, but gram-positive cocaine 1 bottle.
Sir, this was day 1 of illness, no, sir?
Yeah.
This is the same patient, no?
Yeah, same patient.
So day of illness is 1, no?
Preterm neonate, yes.
Yes, day of illness. So why we are thinking of sepsis rather than we should think of HMD in this case?
So they have given, so initially the child has received antenatal steroid, child has received postnatal surfactant, everything has been given, still child is not improving.
So we have to escalate the respiratory support here.
Yeah, so
no
the child is already
PRO,
on respiratory support.
So
child
we will not even think of EOS here, early onset sepsis. That is what I want to say. We will not even think of early onset because it is immediate.
Yeah, I know, but the child is deteriorating. There is tachypnea at birth, since birth only.
So we have to escalate
We are
the
given appropriate respiratory support. All appropriate respiratory support has been given, still child is not improving.
Means improving means what? Is saturation low or is clinically patient is not?
Yeah,
improving?
clinically is not improving.
Saturation low, then this child requires respiratory support, which requires surfactant or intubation, ventilation, rather
So
than
if the child comes to you with tachypnea, distress, you have done all respiratory support, still child is not improving, so you will not send septic screen?
No, not on day 1. Unless the mother has a history of PROM. I will escalate the respiratory support here. So respiratory support means what respiratory support this patient is getting?
So in practical scenario, if you have got child in your NICU, he is having respiratory distress.
On day 1, I am immediately.
Yeah, on day 1. He is having respiratory distress. And child has been given antenatal steroid, child has given surfactant and everything.
Preterm, what is the gestational age approximately?
28 weeks.
Yeah, so high chances that this is a patient of HMD. This might have a PDA also, which is a...
Yeah, it needs to be ruled. So it has to be ruled out.
Yeah, but not so aggressive.
So not ruling out sepsis in sick preterm neonate and just thinking that it can
My contention is that we should focus more on respiratory support here rather than infection. Yes, if 2 days have happened in the ICU, your patient had improved, now he is deteriorating.
Agreed.
Then I
agreed.
will say of early
Agreed,
onset
agreed,
sepsis.
agreed. Respiratory support
And
has to be.
in spite of culture being negative, I will still treat this as a sepsis on clinical suspicion. I will not stop antibiotic just because culture is negative, because the rate is only 50 to 60%. In our own study, it was only 50% positivity.
No problems. That's what I'm saying. That's why our stewardship is there. So blood culture, day 2 showed gram-positive cocaine 1 bottle. Baby still on CPAP, no tachycardia shock.
So here gram positive again is not what I am expecting. I am expecting gram negative. This could be a contaminant.
That's why we're going further, sir. That's why we're going further. So if gram-positive cocci are there, how much significance? You will repeat CRP, add vancomycin, which are the likely organisms, how to identify rapidly. So what are the organisms? So possible organisms in gram-positive. Gram-negative असतं, gram-positive मध्ये possible organisms काय असतील? Staph aureus, very rare, very less common in early onset sepsis. Very, very less common. But the treatment wise, you can start cefazolin, vanco wherever needed. Cons, coagulation negative staph, usually transmitted horizontally from mother to child, very rare possibility. Unusually cause of, but it is again unusual cause of early onset sepsis. Strep agalactici, group B streptococcus, GBS. Yeah, it is important cause of early onset sepsis, but in India, GBS incidence is very low. It is more common in Western scenario. Again, the ampicillin is the drug of choice. That's why we were started with ampicillin and amikacin initially. Again, the enterococci can cause early onset sepsis. E. fecalis is a urinary pathogen. E. faecium is nosocomial pathogen. So these are the possible pathogens. Now, if you want at all to rule out whether this pathogen is really significant or not, what test you have got? So this is the MALDI top test. This is matrix assisted laser desorption ionization, time of flight mass spectrometry. It gives rapid ID from a positive blood culture flag as early as 6 hours and detects more gram-negative bacilli, yes, than gram-positive cocci. But the problem is it will not give you drug susceptibility. The cost of installation of instrument is very high, but the running cost is very low. So if we can have this test, then it is very good to very rapidly diagnose, isolate what the label, which is the organism is there. But the problem is high installation cost and problem with polymicrobial culture. But this test is available, it is being used, and it is very useful in managing ICU patients. That's why we're discussing it. And case conclusion, same day, MALDI was done, staph hemolyticus was isolated. Repeat CRP was 1 milligram. Next day, blood culture also showed staph hemolyticus. So antibiotics were stopped. As Sir earlier said, this is very less likely to be early onset sepsis. And as baby's oxygenation was better, and this was contaminants in blood culture. Microorganism oscillated from a blood culture that was introduced during specimen collection or processing. Common organism cons, micrococci, diphtheroids, bacillus, cutibacterium. Contamination rate should be less than 3% of all blood cultures. आपली standard जी procedure, आपले hospital आहे, lab आहे, म्हणजे आपलं setup आहे. So it should be, everybody should be taught proper techniques of collecting specimens, how aseptic precautions are to be taken. And if you get organism by chance, kutla ala gram-positive organism, gram-negative, so it causes further tests, unnecessary antibiotic exposure, increased cost, length of stay increases, tests are increased. So asepsis is also. So what we discussed initially, good volume should be there, 2 sets should be there. Now asepsis should be also there. Proper asepsis in taking blood culture sample is also important. जर नाही घेतलं तर विनाकारण हे सगळं वाढत जातं. Okay, so that is the clear-cut message. So serial biomarkers are useful in early onset sepsis to stop antibiotics. As sir said, negative predictive value चांगली आहे rather than positive predictive value when low clinical probability of early onset sepsis cannot be used to decide initiation of antibiotics. So based only on inflammatory markers आपण antibiotic द्यायचे नाही ते ठरवू नाही शकत. Contaminants in culture should be recognized and treatment avoided. Cons can be causative organism in late onset sepsis, not early onset sepsis, especially preterm if CVC is in place. The central line असेल तर किंवा multiple culture positives असतील तर so त्यामध्ये तुम्ही strongly suspect करू शकता cons आला तर. Now rapid diagnostic tests. Cultures are considered to be gold standard for diagnosis but can be negative and have long turnaround time. Rapid tests have revolutionized the diagnosis of infectious diseases. Include stains and wet mounts, gram stain, AB stain, serological tests like CART test, immunochromatography test, lateral flow assay, even ELISA, molecular test. But सगळ्या टेस्ट जरी आल्या असल्या तरी culture still have their own place and give information on susceptibility, hence must be sent if indicated. So the whole scenario is की culture पाठवायचं, गुड अमाऊंटमध्ये पाठवायचं, 2 सेट्स पाठवायचे, असेप्टिक प्रिकॉशन घेऊन पाठवायचं. सो द होल आयडिया इज की कल्चर पाठवायचं आणि प्रॉपर मेथडने पाठवायचं. So this is again all the molecular tests are available, PCRs are available, how they help us to shorten the duration. ह्यांनी ते दाखवले वरती की ब्लड ड्रॉन, पॉझिटिव्ह ब्लड कल्चर, ग्रॅम स्टेन, मग स्टँडर्ड मेथडने त्याची आयडेंटिफिकेशन आणि ससेप्टिव्हिटी आली. सो त्याच्यामध्ये 3 ते 4 दिवस जातात. If you use a rapid molecular identification test, you can cut short the duration to 2 days also. So this is the beauty of PCRs or rapid diagnostic tests. Of course, these tests are costly, so you need to use them judiciously in cases. So case for 9-year child admitted with fever, refractory status epilepticus, has received ceftriaxone doxycycline for 3 days. डॉक्सी ॲड केलं होतं. हे आहे तसं आहे. ट्रान्सफर्ड फॉर फर्दर केअर, इंट्युबेटेड, हॅज अ सेंट्रल लाईन इन प्लेस, राईट फिमोरल अँड युरिनरी कॅथेटर. नाव ऑन IV मिथाइलप्रेड फॉर ऑटोइम्युन एन्केफलायटिस. दे आर सस्पेक्टिंग ऑटोइम्युन एन्केफलायटिस. त्याच्यानुसार त्यांनी IV मिथाइलप्रेड पण चालू केलेलं आहे. ओके, 9-year-old child. Nowadays एन्केफलायटिस आर मोर ऑटोइम्युन वी आर सीइंग रादर दॅन इन्फेक्टिव्ह. जर तुम्ही ICUमध्ये बघायला गेलात तर एन्केफलायट आधी जसे इन्फेक्टिव्ह असायचे तसं आता ऑटोइम्युनचं प्रमाण पण वाढत चाललेलं आहे. सो डे 5 ऑफ ICU स्टे, नो फीवर, टॅकिकार्डिया, शॉक, नो चेंज इन ऑक्सिजनेशन, इन्क्रीज टक्केल सिक्रेशन्स, हॅड सुप्राप्युबिक टेंडरनेस. WBC count, suprapubic tenderness, mind well. So WBC count 21,000 with neutrophilic predominance, chest X-ray, no new infiltrates. Possible infections and causes of fever, CLABSI, COTI. What test to do? COTI म्हणजे काय? What is COTI? Catheter associated. What is CLABSI? Central line associated. Okay. So urine routine and urine. So because child had a suprapubic tenderness, child was saying suprapubic tenderness. Urine routine, urine and blood cultures are to be sent. Urine routine more than 10 pastilles, nitrate, leukocyte esterase was positive. Blood culture central and peripheral. Remember, if you have central line, ते 2 सेट्स पाठवायचे, त्यातला एक पेरिफरल घ्यायचा आणि डेफिनेटली सेंट्रल लाईनचा घ्यायचा. ओके, सो इट विल हेल्प अस टू डिफरेशिएट बिटवीन क्लॅप्सी ऑल्सो. ओल्ड फोलीज, जर कॉटी सस्पेक्टेड असेल तर ओल्ड फोलीज हॅज टू बी रिमूव्ड. डोंट सेंड सॅम्पल फ्रॉम दॅट कॅथेटर. ओल्ड फोली हॅज टू बी रिमूव्ड. युरिन कल्चर सेंड फ्रॉम न्यूली इन्सर्टेड फोलीज. ब्लड अँड युरिन कल्चर्स रिपोर्टेड ॲज ग्रोईंग ग्रॅम निगेटिव्ह बॅसिला द नेक्स्ट डे. या पेशंटमध्ये ब्लड अँड युरिन कल्चरमध्ये पण दोघींमध्ये ग्रॅम निगेटिव्ह बॅसिला आला. चाइल्ड इज ऑन मेरोपेनम अँड कोलिस्टीन, स्टील इज इन शॉक. सो ग्रॅम निगेटिव्ह बॅक्टेरिया ब्लडमध्ये पण आहे, युरिनमध्ये पण आहे, मेरोकोलिस्टीन आहे, स्टील इन शॉक, नॉट इम्प्रूव्हिंग. हाऊ टू ऑप्टिमाइज अँटीबायोटिक थेरपी? एनी रॅपिड टेस्ट विल हेल्प अस. ग्रॅम निगेटिव्ह बॅसिला. सो वी हॅव डिस्कस दिस इन द मॉर्निंग. So gram-negative bacilli in blood in PICU patient, determine if it is a carbapenemase producer, determine enzymatic mechanism of resistance of E. coli and Klebsiella. So what are the gram-negative organisms we routinely encounter? E. coli, Klebsiella, Pseudomonas acinetobacter. हे दोन इकडे, हे दोन इकडे. E. coli, Klebsiella इकडे, Pseudomonas acinetobacter इकडे. डिफरन्स काय दोघांमधला आपण बघणार आहोत. Pseudomonas acinetobacter can have both enzymatic and non-enzymatic mechanism of resistance, like efflux pumps, Puri channels, as sir has told in the morning, की ते फक्त एन्झायमॅटिक ॲक्शन्सनेच नाही काम करत, तर त्यांना बाकी नॉन एन्झायमॅटिक ॲक्शन्स पण आहेत. पण E. coli, Klebsiella ते ऑर्गॅनिझम प्रोड्यूस कार्बापेनेमेज एन्झाईम. सो त्यांचा रेझिस्टन्स हा प्युअरली एन्झायमॅटिक ॲक्शनमुळे. ओके, सो नो युअर अँटीबायोग्राम टू डिसाईड इम्पेरिकल थेरपी टिल यू हॅव ड्रग ससेप्टिबिलिटी रिपोर्ट. सो आपल्या ICU मधला एक अँटीबायोग्राम आपल्या डोक्यामध्ये असलं पाहिजे आयडियली, की आपले आपल्या ICU मध्ये कुठलं कॉमन आहे, आपल्या एरियामध्ये कुठलं कॉमन आहे, त्यानुसार आपला एक अँटीबायोग्राम ठरलेला असला पाहिजे. नाव इन दिस केस व्हॉट वी हॅव टू आस्क, जर तो आपल्याला आला आहे ग्रॅम निगेटिव्ह, तर काय कसं डिफरन्शिएट करणार? बिफोर आपण मायक्रोबायोलॉजिस्टने आपल्याला सांगायच्या आधी की हा ऑर्गॅनिझम आहे, हाऊ वी कॅन डिफरन्शिएट, इज इट ग्रोईंग इन ॲरोबिक और ॲनोरेबिक बॉटल? वी कॅन आस्क इफ द ग्रोईंग ऑन प्लेट, दॅट इज इफ इट इज लॅक्टोज फर्मेंटर और नॉन लॅक्टोज फर्मेंटर. अँड आपल्या पेशंटमध्ये 4 बॉटल्स पाठवल्या होत्या, सगळ्यांवरती ग्रॅम निगेटिव्ह बॅक्टेरिया आला आहे. नाव व्हॉट इज द ॲरोबिक आणि ॲनोरोबिक बॉटलमध्ये काय त्याचा डिफरन्स काय असू शकतो की ई कोलाय क्लेप्शियला एन्ट्रोबॅक्टेरिया कॅन ग्रो बोथ इन ॲरोबिक अँड ॲनोरोबिक. सो दोन्हीमध्ये ग्रोथ आली असेल तर ई कोलाय क्लॅप्शियला मोर लाईकली, आणि फक्त ह्याच्यामध्ये आली असेल ॲरोबिकमध्ये आली असेल तर इंटरबॅक्टेरियल ग्रुप लाईक सुडोमोनास, ॲस्टिनोटोबॅक्टर, बर्कलेरिया दे आर मोर लाईकली. ऑल्सो दे आर नॉन लॅक्टोज फर्मेंटर. सो ऑनली ॲरोबिक, नॉन लॅक्टोज फर्मेंटर, ॲरोबिक, ॲनोरोबिक, लॅक्टोज फर्मेंटर, दिस विल हेल्प अस टू डिफरन्शिएट. बेसिकली हे सगळं असण्यासाठी आपला मायक्रोबायोलॉजिस्ट फ्रेंड चांगला पाहिजे. म्हणजे एनी आय डी प्रॅक्टिस कॅनॉट बी डन विदाउट मायक्रोबायोलॉजी, गुड मायक्रोबायोलॉजिस्ट. तर आपल्या जर इफ यू आर प्रॅक्टिसिंग इन ICU अँड इफ यू आर सेंडिंग कल्चर्स, यू नीड टू हॅव गुड रॅपो विथ युअर मायक्रोबायोलॉजिस्ट. त्यांना रात्री उठून पण सांगायला पाहिजे 12 वाजता की अरे ग्रोथ फ्लॅग झाली आहे बरं का. So we can take decision based on that. So we need to have good relations with our microbiologists also. So what rapid test can you do to identify bug resistant mechanism? As already discussed, expert carba R. It is PCR based test based on blood culture flags in rapid diagnosis. As sir already told, it detects carbamazepine for 5 different genes are there. Sensitivity 95 to 100%, specificity 97 to 19%. Turnaround time is very short. Useful only in interbacterial. E. coli Klebsiella असेल तरच आपल्याला ते युजफुल आहे. ओके. सो मग आपल्या जर तो ग्रोथ नॉन लॅक्टस फर्मेंटर असेल आणि फक्त एरोबिकमध्ये असेल तर लेस लाईकली, मग त्यावेळी तुम्ही विचार करा पाठवायचं की नाही. बट इफ ग्रॅम निगेटिव्ह बॅक्टेरिया आणि यू आर हायली सस्पेक्टिंग ते इकोलाय क्लेप्शियला आहे, देन डेफिनेटली यू डू एक्सपर्ट कार्बा. सो आयडियली यूज माल्डिटॉप फॉर ID टू कन्फर्म द आयसोलेट and expert carba for carbapenem resistant detection. And in our patient OXA48 was detected, NDM was not detected. So what is the difference if OXA and NDM is detected? As sir has told, if NDM is detected, only ceftazidime avibactam will not work. We have to add azithromycin also. So in our patients, we started on ceftazidime avibactam, colistin meropenem was stopped and completed 7 days course and child recovered very well. So this is the beauty of rapid test. Again, we have film array BCID panel also. This is blood culture blood panel. It is FDA approved platform. It is highly multiplexed nested PCR test, can detect up to 33 pathogens, 10 resistance genes. Turnaround time 1 hour from the time of blood culture flag. म्हणजे ब्लड कल्चर फ्लॅग झाल्यानंतर त्याच्यातलं ते घेऊन तर तुम्ही हे केलं BCID पॅनल तर पण खूप कॉस्टली आहे. सो यू डिसाइड वेदर यू वॉन्ट टू गो फॉर इट. पण जर पेशंट अगदीच सिरियस असेल, क्रिटिकल असेल, देन यू कॅन थिंक ऑफ डुईंग दिस पॅनल ऑल्सो. दिस इज ऑल्सो अवेलेबल. Case 5, 20-day-old term neonate, birth weight 3 kg, born by vaginal delivery, discharged at 36 hours of birth, breastfed, gaining weight, develop fever on day 21 of life with irritability, fever, feeding reduced. 21 दिवसाचा आहे. So obviously this is late onset sepsis. Pink perfusion good, heart rate 170. We are suspecting, no, it is not diagnosed. We can suspect late onset sepsis. The child is pink, perfusion good, heart rate, tachycardia, irritability, AF flush, generalized hypertonia. Rest of examination is normal. Develops 1 episode of generalized seizures at admission lasting for about 2 minutes. Clinical diagnosis. So we are suspecting sepsis. We are suspecting some meningoencephalitis also because त्याला seizures आलेले आहेत 2 मिनिटाचे 1 episode. Okay. So late onset sepsis with meningitis, most likely bacterial असू शकतं, viral असू शकतं. We cannot differentiate right now. Dehydration fever with hypernatremia causing seizure, very less likely. Inborn errors of metabolism, 21 days एवढं late presentation, GS, glycogen storage disorder, organism acidemias असू शकतात, but it is again very rare. So initial lab काय पाठवणार अशा पेशंटमध्ये? So we should send CBC, CRP, electrolytes, blood glucose, renal and liver function test, urine routine, blood culture and CSF analysis. Now in late onset sepsis, CBC, CRP, PCT, blood culture at least 1 by peripheral vein culture. आता हे छोटं बाळ आहे त्याच्यामध्ये सॅम्पल येतच असं नाही, पण at least definitely 1 sample तर पाठवायचंच आहे, ideally 2. CSF analysis at baseline, strong clinical suspicion of sepsis, features of meningitis, CSF करायचं आहे. CSF later if the baby has positive blood culture, म्हणजे आधी केलं नाही, पण जर बेबी हॅज पॉझिटिव्ह ब्लड कल्चर किंवा बेबी डज नॉट रिस्पॉन्ड टू अँटीबायोटिक ट्रीटमेंट ऑर अबाउट टू असतील तर नंतर पण डेफिनेटली करायचं आहे, सुरुवातीला केलं नसेल तर. अँड युरिन रुटीन अँड कल्चर्स, इट डिपेंड्स ऑन क्लिनिकल सिनॅरिओ. इफ यू थिंक यू कॅन सेंड इट. What are the child had 12.4 of HB, total count 8,210, platelet 2.2 lakh, CRP 6.6, Billy normal, ASD, ALT, SGOT, SGPT mildly raised, blood glucose 76, calcium 11, ionized calcium 1.1. So now, yeah. Pardon, sir?
CSF, I think, should be done upfront, even before starting treatment. Because
CSF, yes, yes, yes. CSF.
patient has irritability. Means
Yes,
any
yes.
symptom or sign, CSF is must. Otherwise,
Yes. So urine routine was done, blood culture was sent. So they started on meropenem, acyclovir, thinking of probable viral, bacterial, दोन्ही त्यांनी cover केले. Had one more seizure and persistent irritability, hypertonia loaded with phenobarbital, developed new erythematous blanching rash over trunk and thighs, encephalopathy requiring mechanical ventilation. What to do now?
HSV PCR on CSF.
Yeah?
HSV PCR on CSF.
So CSF करायचं, न्यूरोसोनोग्राम करायचं, सिटी ब्रेन करायचं, MRI करायचं. Of course, the CBC was they repeated. So this is the what real world they did. Okay, they repeated CBC 12 HB आला 8080 count आला, platelet count 66,000 झाला. Neurosonogram normal होता. MRI showed extensive restriction diffusion in corpus callosum, internal capsule, periventricular deep white matter thalamus. त्यांनी दिलं para infective inflammatory pathology असू शकते. So platelet count 66,000 आला. So what we should suspect? What further tests we can send? Fever, irritability, 2 episodes of seizure, low platelet count, CRP 6.6. Other parameters are okay.
PCR. PCR. HSV PCR.
Okay. They suspected dengue, current platelet count kami hota. They sent dengue, NS1 IgM, it was negative. CSF they did, cell count was 250 RBCs, 105 WBCs, neutrophil 20%, lymphocyte 80%, glucose 42, protein 121 milligram. They sent me EMI panel, as you said, multiplex PCR on CSF, and it was all negative. Sagda viruses.
HSV negative cannot be taken as a good test because the sensitivity of HSV in biofire of this panel is quite low. It requires 500 copies per ml, but a single standalone HSV it detects only 100 copies per ml.
Okay.
So if you are suspecting HSV, then we are actually sending standalone PCR, HSV PCR.
Okay.
For biofire.
Okay, sir. Okay, sir. 48 hours, yes. Rule out, yes.
Or a negative PCR, a negative MRI, and a negative EEG. That also is okay.
Yes. So we have ruled out normal WBC count with lymphocytosis, eosinopenia, thrombocytopenia, mildly raised AST more than ALT, metabolic parameters normal, MRI suggestive of white matter involvement, CSF or slightly hemorrhagic tap but still high cells with lymphocyte, normal sugar, slightly elevated protein. And so it looks like viral meningitis picture, but common causes like dengue, HSV, paraico, entero, CMV, they have ruled out, they have sent PCRs for that and they were all negative. So what next? What to do with antibiotics and antivirals? So CSF and blood culture showed no growth and they had sent, this is the real world scenario, they sent the dengue and chikungunya combo PCR is available. So they sent it on CSF and they found that chikungunya was detected. Meropenem and acyclovir were stopped on day 3. Child had biphasic pattern of fever till day 7 and child improved. Final diagnosis was chikungunya encephalitis. So this was the case. So take home message is the rapid diagnostic tests are boon in infectious disease diagnosis. Because why we could diagnose this child? Because we had PCRs in our hand. So PCRs are not all that bad. Okay. कुठे करायची कुठे नाही करायची कुठली करायची these are properly केली. I know these are costly tests but they do help you. The take home message that PCRs are costly tests but they definitely do help you in diagnosis. So make a difference in patient outcome if used appropriately. Clinical correlation is a must. False positive, false negatives are problem with this test. Still, so can treat patients on basis of syndromic approach where cost is a limitation. However, finding an etiological agent increases the confidence, helping in optimizing therapy. So seek expert ID advice in unusual cases and reports. Thank you. Thank you very much.
Now I invite Dr. Pramod Kulkarni sir for next lecture.
So coming to CNS infection, let us come to first case. 12 months male from Kolar, rural area. Fever 2 days, headache, nuchal pain, has nausea, vomiting. On examination, anterior fontanelle is full. Tachycardia, altered sensorium, GCS, E3, V3, M4, has received oral antibiotics before coming here. Classic clinical scenario of acute intracranial infection, mostly encephalitis. Okay? AF is full. So questions ask, brief history, detailed history, stabilize the child, take blood sample, emergency basis, urgent imaging. These are the options, one or more. What will you do in such a case? This child, clinically look at this child. What should be your priority? So, triaging this child is critical. Raised ICP के signs है. So brief history, stabilize the child, take the samples. These are the three important things we have to do. Okay. So the temperature was 102. Random blood sugar was 60. Sodium was 125. Urea 10. Ionic calcium 5. Patient was resuscitated. Dextrose sodium correction started. History. Immunization history, child has received all except pneumococcal conjugate. Local epidemiology, no epidemics running. Physical examination, no rash, pupil sequel and reactive. No signs of neurodeficit due to raised ICP. Provisional diagnosis of meningoencephalitis was done. How will you proceed investigations in this child? You have done first task, triaging, resuscitation, stabilization, brief history you have done, basic workup you have done. How will you proceed with the investigation in this case of probable clinical meningoencephalitis? Yes, of course, it's a critical intracranial infection. You will go ahead with the sepsis workup as well as CSF. These are the two things. You will also think of neuroimaging in this case. Think of, as the encephalitis component is there. So CBC, CRP, procalcitonin, blood culture, imaging, EEG. That is important. Whenever encephalopathy or encephalitis is there, all the brain parameters of brain dysfunction have to be tried, and EEG is one, which is definite one. Many a times you may not get anything on imaging, but your EEG will tell you cerebral dysfunction, which is essential criteria of encephalitis or encephalopathy. CRP and procalcitonin, in untreated bacterial infection, both CRP and procalcitonin are highly elevated, even when gram stain is negative. So they are highly suggestive of probable bacterial infection. Procalcitonin drops within 24 hours after antibiotics. Normal CRP has got a good negative predictive value. So the common scenario, let us think of simple febrile seizure, a young baby, you are in a dilemma whether to go ahead with CSF or not. The clinical pointers are very much there. On top of that, if your CRP is normal, you can always wait on the background of other less risk factor or absent risk factor for intracranial infection. Lab investigation in this patient, total count 18,000, platelet 2 lakh, neutro predominant 80%, then band 5%, INR 1.1, APTT 35, culture report awaited, blood sugar 90 milligram. Can we do LP in this child? Yes. So, when will you do? All patients should undergo LP and CSF examination when you are having suspected intracranial infection or encephalopathy. You have to do CSF unless there are proven definite contraindication. So, absolute contraindication, the fluctuating, deteriorating consciousness or GCS less than that, clear signs of raised ICP with impending coning, pupillary inequality, posturing, or Whiteless the Cushing's triad. If it is there, we are not going to do it. A bulging fontanelle in the presence of raised ICP, though it is mentioned as absolute contraindication, we usually do in a meningitis, suspected meningitis case, a guarded or careful LP can be done. A dose of mannitol or 3% given as guarded LP is also acceptable. Relative contraindications, bleeding, hemodynamically unstable baby, respiratory issues there, new focal neurological signs, or seizures immediately within previous half an hour, or child not recovering even after half an hour of cessation of the seizure, or coagulopathy or bleeding tendency in form of platelets less than 50,000 or INR more than 1.5. Again, these are relative contraindications. Okay? What should be done if LP is delayed? You're in a dilemma. LP better not done, not to take risk. Or the parents do not give consent. You have to start the antibiotic therapy empirically because this is intracranial serious infection. So send blood cultures and then start empirical antibiotics. Lumbar puncture to be performed with universal precaution sterile technique. PPE has to be worn by the person performing, and the median depth of needle insertion. Let us not go. Everybody of us has done hundreds of LPs. We know how much it is done. Insertion site we know very well. Spine flexion is very important. Let me remind you that deflection has to be done from shoulder to hip, not the head. Keep it in mind because I have lost my first patient of LP in periphery just because of excessive flexion. Just because of excessive flexion by my assistant. And I got a good CSF and the child was dead. This was very sorry state of affairs. This was 32 years ago. But that was my first death because of the procedure itself. And thereafter I have learned never to apply pressure to head. It is to be applied at the shoulder. Flexion of the lumbar spine is our target. Do it from shoulder and the hips, not by head. Please mind it well. Okay? CSF collection, yes, this needs meticulous attention. You have to have at least 4 or 5 collection tubes minimum. How many of us? Our practice was collect in one tube and transfer it as needed. No, please don't do that. You have to have at least 4 sterile tubes, one for biochemistry, one with EDTA, or if not, to be sent within 30 minutes for cellular examination. Within 30 minutes, I tell you, if not, go for EDTA as well. You have to have fluoride to compare, have a good stable sugar values after long time also to compare with the previously done blood sugar. Then the fourth one in a normal sterile container, which will be useful for our microbiological purposes, and one in culture as well as additional studies where we need them. Okay? Transport time should be less than 15 minutes. Very, very, very important. Do not refrigerate CSF for bacterial culture. After sending all these things, you can preserve that CSF in fridge for molecular studies or serological studies which might be needed afterwards. It is worth doing it. Then a delay can cause cells in CSF to disintegrate, autolysis of the cells. So send it ASAP. Smear and culture should be done as early as possible. It is said that you better take it in a syringe and transfer it to the blood culture bottle of Bactec. It is always better to do that rather than sending CSF and the time lapse between that. So if there is a delay, prepare a smear, transfer the CSF to the blood culture bottle, and the cell examination, not cytology actually, cellular examination, microscopic examination of cell with direct counter loading Newbar chamber as well as smear for differentiation has to be done immediately as soon as possible after collection. CSF sugar, you know, you have to collect it in fluoride. A previous just before LP, a blood sugar estimate immediately before LP is mandatory to have good comparison, and hypoglycemia defined by less than 0.6 ratio is definitely suggesting us possibility of bacterial meningitis. What test to ask in CSF? Not cytology, microscopy for cell studies. Sugar, proteins, gram stain, very important, gram stains are very important. Latex agglutination test, there was era when we used to do it, but now they are out of vogue, they are obsolete. Binax for pneumococci, this is one which you can try. You know very well after PCV era, even today, over last 2 years, the meningitis we have got was badly inflammatory, highly malignant meningitis, and all were caused by Streptococcus pneumoniae, with very bad outcome and very bad course. In such a in such a case, when pneumococci are your first target to get, we don't have Hib now with national immunization working for Hib over last more than 10 years now. Anti-HI usually doesn't cause meningitis. So Streptococcus pneumoniae is our the target for pyogenic meningitis. We have a specific antigen test for that, which can be useful to give us diagnosis, especially when the child is treated with antibiotic or if there is a delay in CSF in form of Binax now, which is a pneumococcal antigen test recommended ideally for urine, but can be done in body fluids like pleural fluid, CSF or other body fluids, reliably so to give us Streptococcus pneumoniae as etiology. So it is doable, it's quite cheap, it's not very expensive, 2,000 rupees, can be done in the ICUs itself, it's a lateral flow technique, there is no much issue about that. This can be done, this is recommended because you get specific microbiological diagnosis and that too in very short time. Binax. Then CSF culture, a standard has to be done. PCR and antibody for viral infection, yes, highly desirable, especially when you have got a critical, non-responding, worsening child or a encephalitis component higher and an epidemic going on. In these cases, you definitely think of the emipanel and moleculars for that. And again, antibody, rarely you will have to look for the, as in this case, maybe JE, in dengue, you will have to do CSF antibody titers also. If the antigen or PCR is negative, that can be of use for diagnosis. Gram-stain, highly specific, 97%. Don't forget, it is the most useful early test. Sensitivity is variable, but do try it without forgetting, and you will get the reports within 2 hours of collection of CSF. Type of pathogen, cytocentrifugation, severity of infection, all determine the inoculum of bacteria in the CSF, which will determine the positivity or sensitivity of it. Laboratory personal experience is telling, number of slides prepared, and patient's exposure to antibiotic. These are all going to determine the culture positivity. But you know, with dead organisms, your PCR antigen test are going to be useful. Gram-stain culture, acute bacterial meningitis can be diagnosed with more than 99% certainty with following CSF measurements. Glucose less than 34, proteins greater than 220, WBCs more than 2000 or predominant neutrophils. These are suggestive of acute bacterial meningitis. Again, it depends on the stage of the disease, at what stage you have done CSF. Again, exposure to antibiotics, the organism and all this. But this is just a rough guideline when ABM is likely to be there. Latex agglutination test, as I told you, were in use, but the sensitivity is very low. Nowadays, they are not in use. Rapid antigen test, as we have seen. What organisms we can do? Rapid antigen, one we have already seen. Streptococcus pneumoniae. Then we have got group A Streptococcus antigen available, as well as COVID-19. Nowadays we don't have COVID, but meningoencephalitis, COVID as a causative agent, we would have thought of it, and the rapid antigen test could have been done. So Binax now, as I have said, Streptococcus pneumoniae, Binax now, COVID-19 are approved and can be done. How to interpret traumatic LP? To be very frank, don't interpret by the variable host responses like cell count, sugar, and protein. That is the most inferior way of interpretation and diagnosing meningitis into a partially treated acute bacterial, viral, aseptic. Please don't do it. Microbiology, culture, and Gram-stain and PCR are going to be of great help even in a traumatic CSF sample. They are going to be highly reliable. But if it is partially treated or if it is not reliable, please don't go ahead. There are correction formula for sugar, there are comparison with the blood counts, there are correction for the protein. Please don't do it, it is not the right way. We are looking at microbiological diagnosis and not the indirect host responses. There are some indications formula, but please do not look at those. So, microbiological direct tests are reliable. Interpretation of LP when already receiving antibiotic, CSF culture will be negative, Gram-stain is likely to be positive if done, if antibiotic is given for just some time, even if the dead bacteria can be picked up by gram stain. And gram-negative enteric bacilli are highly sensitive to antibiotic therapy. They get killed and disintegrate earlier. Pleocytosis, elevated protein, reduced glucose, persists for several days. Don't repeat it for monitoring of acute bacterial meningitis. PCR may be useful. Role of PCR, yes, culture remains the gold standard. Why? It gives you organism, not only organism, antimicrobial susceptibility, so important to modulate your ongoing continuation or de-escalation of your antibiotic therapy. Partially treated acute meningitis, viral infection is suspected, faster are the indications of a role for PCR. These are fast tests and definitive treatment can be modulated in viral infection as in acyclovir in HSV disease, as well as antibacterials in diagnosed bacterial pathogen and its susceptibility. And discontinuation, you know, with different bacteria, the duration of treatment is different. Role of encephalitis panel can identify treatable causes of viral encephalitis like HSV 1 and 2, with the drawback as said, the cutoff is single cutoff, standalone PCRs are far better. HHV 6, influenza, HIV, COVID, CMV and varicella zoster. These are the available PCR panels in the ME panel. And we have the bacteria as well. What it doesn't have, 4 important organisms which are prevalent in India, not picked up by your ME panel are, number 1, dengue, number 2, rickettsia, number 3, TB. These are the 3 important ones which are not, and JE is the 4th one, not picked up by your ME panel. If you are suspecting these, you will have to do specific tests for them. What are the disadvantages? False positivity, false negativity. Not all pathogens are detected by panel, that is what we saw. Unable to provide antimicrobial susceptibility. It gives you organism, not the susceptibility. Positive result for HSV due to latency or reactivation of virus with or without disease. So false negative in early stage, false positive in a chronic case, reactivation disease. It doesn't say it is active disease or what. And the high cost rate, but definitely intracranial infection is the critical infection where it is worth spending 12,000, 14,000 rupees to get a specific microbiological diagnosis. So it is highly recommended. Of the available multiplex PCR or the film array, which is most desirable and should be used with least discretion, is the ME panel, which is most desiring set which is available you should do for intracranial infections. So in our case, CSF showed 500 WBC, 20% polylympho 80%, sugar was 40, blood sugar 80, proteins were 150, gram stain negative, culture awaited, total count 18,000, Procat 2 microgram, CRP 30 milligram per liter. What's your opinion? What is this? So applying all these things to our case with these results, what do you think? Looks like viral. So again we treat it empirically. Meningoencephalitis AES we treat empirically, covering all, but with the reports we can modulate our antimicrobial therapy. This child was started rightly on ceftriaxone, vancomycin, acyclovir. In endemic areas we have to think of doxycycline as well as antimalarials as polytherapy empiric for acute encephalitis syndrome. This child developed generalized seizure lasting 2 minutes, treated with anti-epileptic drugs. Seizures, another few episodes. What is it? What is it? We have said CSF we have got, probably viral here and there. The child is being treated empirically with antimicrobial agents and the child is worsening. New onset seizures beyond first few days. Not only that, repeated seizures. What does it mean? Ongoing increasing encephalitis component, okay, or a local complication. What will you do in this case? Directly autoimmune workup. Intracranial infection, you will think of something else also. This is meningitis. Yes? Yes, definitely. So in this child, again to look at the metabolic status, things were done. EEG will you do in this case? Definitely you will do. Seizure is the new problem. EEG is essential component of encephalitis workup. So EEG is and neuroimaging definitely the first step to be done. What is happening locally? We see non-responding or worsening intracranial infection. There is likelihood of intracranial complication. To look at that, we have to do neuroimaging also. So indication of imaging in such a case, patients who do not respond well to treatment, atypical presenting cases, persistence of fever or new onset neurodeficits. To screen for ENT cause of bacterial meningitis, there can be an associated otitis media with mastoiditis or a sinusitis, ethmoid sinusitis, or a cerebral venous sinus thrombosis, which is complicating or causing this intracranial infection. So to look at all these common local lesions, you have to do neuroimaging when you are suspecting. In this case, do you want to do? Yes, definitely in this case. And role of EEG in acute febrile encephalopathy. AFib patient should undergo EEG as soon as feasible when seizures occur to rule out non-convulsive status, focal encephalitis versus generalized encephalopathy. Findings suggestive, we know all, plaids, generalized diffuse slowing of the waves, and plaids are the typical one suggesting. So CSF report of this child. In this child, the CSF culture grew Pseudomonas putida. What is your opinion? How will you interpret? I also don't know much about this organism. So what is it? This is meningoencephalitis. Pseudomonas causing meningoencephalitis, that too putida, something unknown. We'll have to review the literature about the organism. Is it a common pathogen? I don't say. I'll consult my microbiologist or ID person, or I will review the online resources to look at this organism. Is it really known to cause this intracranial disease or not? So it is most likely to be a contaminant because of skin was not prepared properly in this case. Or the water could be contaminated, or at the culturing point it could have been contaminated. So blood culture in this child came negative, saying there was no bacteremia. So etiology unconfirmed now. What is to be done in this case now? Now we go to your autoimmune issue, something beyond infection. This is a meningoencephalitis, persistent, progressive, with the basic things worked out, normal, no local complication. We will think of the other causes. Send the CSF for neuro panel. ME panel के लिए भेजोगे क्या? Definitely भेजेंगे, वो तो पहला है imaging के बाद, उसके पहले ही भेजेंगे. Serology, CSF and blood, कुछ भेजोगे? Definitely there are some infective encephalitis organisms which can be detected by systemic studies. So antibodies in serum as well as antibodies in CSF can be done. Respiratory panel for the evidence of other common infection which can cause meningoencephalitis as atypical presentation or complication. We have to keep all those in mind. And the samples, relevant samples of those particular organisms. Choice of test depends upon history, clinical clues, and local epidemiology. We will test for rickettsia also if this child is having rash and other persistent meningoencephalitis, and we have not added doxycycline. PCR report in this case showed streptococcus pneumoniae. That's the beauty of ME panel. Again, we have got one bug. After all, with ME panel, we have got the bug. Now we can de-escalate rest of the things. That's the important thing. Okay? So, how to proceed ahead? No sensitivity report. So treat it empirically, suggested duration, and looking at the clinical response. Okay? So high index of suspicion is halfway to diagnose pyogenic meningitis. LP is mandatory before starting antibiotics if there is no absolute contraindication. A clean and aseptic LP procedure is a must. Lab investigation as per clinical evaluation, epidemiology, and evaluation of further signs and symptoms. PCR has a definitive role in culture negative meningitis. Please do ME panel in all suspected intracranial infections. All suspected, and neuroimaging in non-responsive, progressive, complicating, atypical of neuroinfections, meningoencephalitis. Altered sensorium seizure in the background of local epidemiology in febrile child, be alert about encephalitis. You have to use EEG as well as the autoimmune workup or the screening for other systemic infection which can complicate. You know, we have seen COVID also coming as encephalitis, GBS and all. All the common viral infection can have atypical presentation as intracranial infection. In case of encephalitis, neuroimaging diseases are essential. Multiplex PCR is worth doing, most dependable. Think of treatable causes of encephalitis. That is about intracrial infections. Thank you.
I invite our next speaker, Dr. Suchita Pofle, madam, for our next talk on fever with lymphadenopathy, diagnostic stewardship.
Is it the right time to stand in between lunch and this last topic? So I thanks Central IIP for making me this part of this illustrious faculties. Pramod Kulkarni sir, who knows in and out of every infection, Dr. Keyur and Aishwarya, emerging ID experts. And let's come out of the ICU now. We are sitting in comfortable OPD environment, and then we are looking after in the cervical lymphadenopathy. पहिल्यांदा तर असं म्हणायचं की पहिल्यांदा पेशंट जेव्हा येतो फीवर विथ लिम्फॅडिनोपॅथी, मग पहिल्यांदा सांगतो पेशंट की मॅडम ताप आला आहे, आणि मग आपला हात आणि त्याचाही हात गालाला गळ्याभोवती घेतो आणि म्हणतो बघा इथे इथे गाठी लागत आहेत, आणि ह्या गाठी तो म्हणतो की मग काय करायचं, एक एक्सरे करून घ्या मॅडम. मग एक्सरे करायचा आहे किंवा मशीनमध्ये घाला, ह्याचा प्रवास एक्सपर्ट्सनी कसा उलगडला आहे आपण लेट्स सी. We'll directly go to her case. She's a 12-year girl in OPD, swelling in left submandibular region for the last 10 days. She has history of undocumented fever. We are not sure of the fever for 8 to 10 days. No history of cough, rash, or appetite loss, or any no other localizing symptoms clinically, which we have uncovered, like ear infection, dental infections, pyodermas on the scalp, or wherever pyodermas on the face, neck area, and non-contributory past medical and family history, like tuberculosis history. Received 3 days of co-amoxicillin in inadequate doses given by some chemist. So shall we ask something else or shall we go forward now? So is it a significant in lymphadenopathy or not? The patient has noticed the lymphadenopathy. Is it a significant one? Yes. So let's go in next. She is a thin and malnourished girl. A single diffuse swelling, 4 into 3 centimeter in the left submandibular region. The ill-defined borders, smooth surface, firm in consistency, tender, non-fluctuant, non-compressible. It's mobile and shows no signs of matting. So from this, what we can at least guess, it is a significant lymphadenopathy. Yes, it is. Then few sub-centimeter cervical lymph nodes present in the right side of the anterior triangle. No other lymph nodes palpable in supraclavicular, axillary, or no hepatosplenomegaly. She is mildly pale, mild pharyngeal congestion. It is specific. Tonsils appear normal, and other systems are normal, no HS megaly. So where are we now? What are the possible DDs? Yes. So is it an acute one or a chronic? It is acute. 10 days it is an acute one. So where it is, she is a young girl, 12 years girl. So what we are suspecting?
Acute inflammatory lymphadenopathy.
Okay. So what are the possible DDs? Let's see where. Any other DDs apart from inflammatory lymphadenopathy?
You have to see the throat examination and.
So they said the throat examination on. Why we want to say throat examination?
Oral examination. See any tonsillar enlargement.
Enlargement.
Any infected caries tooth or
any local pathology causing reactive lymphadenopathy.
Yes.
So first is reactive. So can this be reactive lymphadenopathy?
Yes.
It can be reactive lymphadenopathy, but there are no focus in the draining area, and the size is a bit big for reactive lymphadenopathy. Can it be bacterial, partially treated? She has received inadequate doses of co-amoxicillin. Yes, it can be. Can it be tuberculosis? Less likely. Why? Because
acute, it is acute.
if it is acute, both the symptoms symptomatically, the symptom, she has started fever and lymphadenopathy at the same time. Malignancy, no other systemic signs or symptoms. So these are the, in this order we are suspecting. But the first is partially treated bacterial or other miscellaneous causes, Epstein-Barr virus, HIV, SLE and Kikuchi's disease. So what to do next? These are the 4 options. Continue coamoxicillin, adequate dosage, high dose of ampicillin, analgesics and investigate. What we should do now? Any thoughts? Let's see what the experts say. Yes, this may be a partially treated bacterial adenitis. So continue with adequate dosage of amoxicillin for 10 days. High dose of amoxicillin, no. Analgesic, no. And we need to investigate the child. So these are the common, we have seen CBC, CRP, ESR. These are, we are going to do it definitely. And the child had mild pallor with TLC almost normal and reactive lymphocytes. The lymphocytosis is 22 lymphocyte count, but with reactive lymphocytes. Platelet is slightly lower side, and we are not getting anything from CRP and ESR. So where are we? Can we come to any inference from this? Except from reactive lymphocytosis, but there the lymphocyte count is low. Can we come to any conclusion from this slide? Are the patients? No, I'm not getting.
Absolute lymphocyte count is quite low.
Yes. So reactive lymphocytosis.
So absolute lymphocytes count is low actually.
Actually low. So if we are suspecting Epstein-Barr virus, then it would have been more. Lymphocytosis would have been more.
But still it is written reactive lymphocytosis.
Yes.
Lymphocytes, not cytosis.
PB.
Yes. Atypical. They are atypical.
Atypical. So the thrombosis. Okay, let's see. No abnormal cells, at least on PS, but we are not sure. The ALT, AST are also normal, and EBV, VCA, IgM positive. I don't know why it was sent by resident. That means they want to send that responsibility on the resident that he has done it. So is it rational or irrational? Sending the EBV, VCA, IgM.
Sending is irrational. Report is rational.
It is rational or irrational?
It is rational to send.
It is rational. Yes, it is rational.
In this
but
scenario,
still,
I missed the first part actually.
Sir,
I missed the first history part, but it seems it is rational.
It seems rational. It is. Yes. Oh. Yes, sir. Yes. So rationality of EBV, VCA, IgM is mononuclear syndrome. Mostly, we need a triad of fever, pharyngitis. With usually the lymphadenopathy is generalized. There is maybe splenomegaly. In 50% of cases, that there will be splenomegaly. Lymphocytosis, atypical lymphocytes more than 40%, and liver enzymes raised. The causes are EBV, cytomegalo, toxoplasma, or viruses, HIV, rubella. So point not favoring EBV in this case was non-exit, means there was no triad of fever, pharyngitis, and no lymphocytosis on smear, no transaminitis, no splenomegaly, but all still, in some cases you can get this. what the IgM which we have done is suggestive of acute infection which comes in 4 to 6 weeks and may remain positive for at least 3 months. But to categorically diagnose acute EBV infections, especially doubtful cases when there are no symptoms like in this case, we need to have EBV VCA IgM positive with EBNA nucleic acid, Epstein-Barr nucleic acid and IgG negative. That means it will start raising between 3 to 5 months and it may remain lifelong. So diagnose acute infection, you need to have these 2 cases. So that was the reason why along with this could have been sent. So what are the imagings at these stages? So everyone is tired of answering now. Let's go directly to case. The chest X-ray, USG of the abdomen and CT neck. Which are the investigations you will recommend? USG neck. And X-ray of course. X-ray hilar prominence and USG neck necrotizing lymphadenopathy. In fact, USG is a very good modality to do accessible as well as inaccessible lymph nodes, and it is a first line investigations. So the FNAC along with ultrasound imaging has a sensitivity pattern 92 and specificity 97 in distinguishing from benign from reactive lymph node disease, and which sonographical features which help to identify abnormal nodes are the shape. Shape is usually round in malignant while oval in reactive lymph nodes. There is absent hilum, intranodal necrosis, reticulation, calcification, matting, soft tissue edema suggest tuberculosis or malignancy. Matting, of course, tuberculosis, and vascular distortion. In malignancy, there is vascular distortion, while in tuberculosis, because there is vascular dilatation or pockets of vascular dilatation in sonographic findings. But it cannot provide definitely microbiological or tissue diagnosis. In this case, hypoechoic round without echogenic hilus tend to show intranodal cystic necrosis. This is pathological definitely. Nodal matting and adjacent soft tissue edema. Still we are not clear whether it is tuberculous or not. On color Doppler, the vascular distribution is tuberculosis. We have seen displacement of hilar vascularity, while in malignancy it is complete distortion, and the differentiated feature from neck metastasis are nodal matting, surrounding soft tissue edema, no homogeneity, intranodal necrosis and posterior enhancement. So the child was treated with amoxicillin adequate dosage, and 10 days more have passed, and still there is fever persisting, which is low grade. Now it is a documented one, and lymph node has still increased in size and tenderness gone. What this suggests? Yes. Now we have to go further in the investigations. Wait and watch? नाही, आता तर शक्य नाही. पेशंट थांबणारच नाही मग आपल्याकडे. ट्राय लिनिझोलाइड का तर अमॉक्सिक्लाव्हला रिस्पॉन्ड करत नाही आहे, आणि 2 ऑर्गॅनिझम स्ट्रेप आणि स्टॅफ आहेत आपल्या हातामध्ये जे की बॅक्टेरियल ॲडिनायटिस करतायत, आणि स्टॅफ आहे म्हणून विदाउट सेन्सिटिव्हिटी पॅटर्न किंवा विदाउट प्रूवन मायक्रोबायोलॉजिकली अगेन वी आर स्टार्टिंग लिनिझोलिड. नो. डू ANA, SLE फक्त आयसोलेटेड lymphadenopathy without any local signs, symptoms, systemic signs, no. ANA 2+ दिलं ह्याच्यात, how to interpret, no distinguishing SLE features, do not react immediately, that's what experts say. Sputum for AFB, CBNAT, still we can do induced sputum, though child does not have any respiratory. TST IGRA, no. USG abdomen to find out lymphadenopathy and hepatosplenomegaly. CT chest, are we going to do this immediately? No. And FNAC of the cervical lymph nodes. मग ते आपल्याला कन्फ्यूज करायलाच दिलेत ना. हो ना डॉक्टर, हे आपल्याला कन्फ्यूज करायला सांगितलंय त्यांनी.
Why not IGRA, madam?
We are already dealing with infection.
Yeah, so that's what I'm saying for tuberculosis, to rule out tuberculosis. No?
So it is for the role.
I'm not saying TT. I'm not saying TT, I'm saying IGRA.
And we are dealing with infection already.
Pardon?
Yes.
Yes.
हे इन्व्हेस्टिगेशन करण्याच्या अगोदर सर पहिलं मी एफएनएसी करेन. इतकं मोठं करत बसणार नाही.
करायचं नाहीच आहे, विचारायचं आहे तुम्हाला, विचारलंय ते.
एफएनएसी करणार.
हां, सो where I practice, FNAC is the best option. And whether FNAC or fine needle aspiration, core biopsy under ultrasound guidance. It is an inexpensive pathologist, or we can do it directly done from the superficial nodes.
Core biopsy is the gold standard.
Yes, but आपण जे करू शकतो OPD मध्ये किंवा पॅथॉलॉजिस्ट करू शकतात ते FNAC. It is specificity is 86% of FNAC also. There are limitations. Limited sample, the distorted cell tissue architecture, then we cannot get anything, and better. So then comes the next option, core biopsy, and here the expertise is needed. Core biopsy has, but the pediatric surgeon need anesthesia lagto. Then their patient may refuse that. That are the limitations of core biopsy, but that has an edge over FNAC. So in our case, the core biopsy showed features of granuloma, and the CB-nat of sample was negative. So what next now? Start tuberculosis empirically, or role of CT MRI, or excision biopsy, which is better? Excision biopsy is better, definitely. Because this is most localized to a localized lymph node, so it is a better choice in this case. If it would have been some systemic signs and other lymphadenopathy, generalized lymphadenopathy, or thoracic mediastinal lymphadenopathy, then would have gone for CT MRI. Excision biopsy was done and samples test for CB-nat, MGIT. So biopsy, when and what type, can be done where FNAC is diagnostic, clinically strong suspicion of TB or malignancy. So excision biopsy is preferred over incisional biopsy, and mediastinal lymph node biopsy done with bronchoscopy, thoracoscope. And mycobacterial tuberculosis can be cultured in 70 to 90% of cases in excisional biopsy. This is how we have to send to the laboratory. Molecular methods comparison is for tuberculosis. CB-nat ultra is the excellent choice, where up to 13 to 16 bacilli per ml can be detected. This is the best. Time is also 2 hours, and the cost of therapy may be high. And the sample sputum compared to pleural fluid. This is the sensitivity and specificity we get from the expert MTB and RIF from different samples, sputum being highest while pleural fluid being lowest. We have seen just now also the pleural fluid has less sensitivity and specificity. So back to this case, excision biopsy revealed histopathologically histiocytic necrotizing lymphadenopathy, that is Kikuchi's disease. Necrosis is equal to TB? No. So granulomas with caseation, it can be MTB or non-tuberculous mycobacteria. Necrotizing granulomas can be found in other diseases also, cat scratch, Yersinia, brucellosis, जे की मी तरी काय पाहिलेले नाही आहेत कधी. आणि necrotizing non-granulomatous are Kikuchi's disease and SLE, Kawasaki. SLE we have not entertained in this. Kawasaki, the age group is not fitting into the Kawasaki and symptoms also. So it is necrotizing non-granulomatous, mostly histiocytic lymphadenitis. So to come towards the final algorithm, X-ray chest in lymphadenopathy, all patients to seek active or previous tuberculosis, HIV, yes. USG and CT chest in selected patients when diagnosis is not clear. FNSC, all cases of lymphadenopathy, significant lymphadenopathy, which have not responded to adequate dosage of antibiotics. And excision biopsy when the inconclusive of FNSC or suspected malignancy. Same the algorithm which we have seen, enlarged lymph node, matted, cold abscess, discharging sinus, then send it for tuberculous microbiology, the diagnosis of tuberculosis. If it is confirmed, treat it as a case. Then if not, antibiotic for 7 days, review after 7 days. If they are non-respond, again the same algorithm follows. And no granuloma, no AFB, consider alternative diagnosis. Lymph node biopsy, isolated Montaux positive without suggestive finding in FNSC should not be treated with ATT. That is important. So take home message, plan a careful follow-up and evaluation. Node biopsy better than FNSC when diagnosis of tuberculosis or FNSC is inconclusive. Caution before empirical steroids. We do not start steroids empirically. No role of empirical ATT also. And routine ANA testing has no role in fever evaluation. मला हा अँटीबायोटिक स्टुअर्डशिपचा जो आपला मॉड्यूल आहे त्याच्याबद्दल एक जुनं हिंदी गाणं आठवलं तर की हाऊ वी हॅव टू अप्रोच टू द डायग्नोसिस. हेमंत कुमारचं कोहरा सिनेमातलं गाणं आहे, राह बनी खुद मंजिल, वी आर नॉट शुअर व्हॉट इज द डायग्नोसिस, पीछे रह गई मुश्किल. इफ यू गो सिस्टमॅटिकली देन यू आर लायकली टू रीच टुवर्ड्स अ डायग्नोसिस. थँक्यू.
Thank you, madam. Thank you very much. I request everybody to come up for the final photograph. Please come up. Meanwhile, I thank Central IIP for giving us opportunity to conduct this module, and also from the Maharashtra IIP, always Dr. Pramod Kulkarni sir is there, Keyur sir, Pofle madam, Dr. Aishwarya madam. They have nicely taken this module. I request everybody to please come up. I request my all office bearers, Dr. Madhusudan, Dr. Vidyanand, Dr. Sandeep Kade, and EB members for always supporting the activity. Thank you. Thank you once again. Please come up.
हे आहे ना साईडला बॅनर ठेवेल, बॅनर येऊ दे.